Matt, before we begin, I just need to do a quick sound check. Testes, 1, 2, 3.
Well, firstly, get your hand out of my pocket. And secondly, that's a golf ball.
Welcome, everybody, to another episode of Dr. Matt and Dr. Mike's medical podcast. See, I keep doing this, but that's okay. We do a lot of A to Zs. If you don't listen to our short form podcast, it's called Dr. Matt and Dr. Mike's A to Z.
I think 6 to 1 maybe.
Of the human body.
Probably,
so
yeah, 6 to 1. Yeah, it's about 6 to 1.
I'm very used to that. But anyway, welcome to the long form episode of Dr. Matt and Dr. Mike's medical podcast. I'm your host, Dr. Mike Todorovich, joined by my co-host, Dr. Matthew Barton. Matt?
Good morning. Good morning.
Still good morning. It's 10:28 a.m., Tuesday the 7th, a little bit ahead of myself, of November, just so everybody knows.
And I'd like to say congratulations to the South Africans. They won the World Cup in rugby.
Did they?
Yeah.
Oh, well, good job.
They beat the Kiwis.
Oh, was that a finals?
It was a final.
When was that?
Last weekend.
Oh, so a whole week ago.
Sad day for us Kiwis.
Are you a Kiwi?
No. My dad is.
Okay. So sad day for your dad. Oh, poor guy.
But 1 point in it.
Really?
If they kicked the goals, they would have won.
Wow. I'm sure everyone's loving this.
So well done, South African. Yeah. To our listeners in South Africa, congratulations.
Well, we do have at least one. We know that.
Yep.
What else have you been doing? You okay?
Good. My eldest had a gastro last week, and that was a rough night.
Yeah, that can
cleaning and vomit every hour.
You didn't get it?
Every hour on the hour. Oh, bed sheets, sleep sacks, everything.
Oh, we get it maybe four times a year, I reckon.
Oh, really? Gastro?
Yeah. I reckon it once every 2-3 months. And generally, my kids are pretty good. They'll spew once, done. Or diarrhea. My wife got it last time. Not nice. Not nice.
Well, I think this was her first.
Really?
Zarina's first, yeah.
Wow.
But the funny thing is, like, in the moment, she's obviously distressed.
Yeah.
But then, like, straight after, she sees it as a game to change all the bed sheets and change the clothes.
Honestly, I think
like 2 in the morning.
There's something to that. Kids don't get upset for too long with these types of things. They're upset in the moment, and then they'll just play again until it's time to spew or poop.
Yeah.
Oh, boy. How'd you go with preparation for today? Because today we're going through the male reproductive system. Last long form was female reproductive system. Mm-hmm. How'd you go with your prep?
Well, spent a lot of time in front of the mirror.
Learning about yourself. So did you have the textbook and just looking going, what is that?
Correct.
That doesn't look like the textbook. All right. Well, at least you learned something for yourself personally.
It's true.
That's good.
True.
I did a bit of prep. Can't say I was looking in the mirror not more than usual, but we're going to work through the male reproductive system today. And we're going to focus on external, internal anatomy, similar to the female reproductive. And we're going to look at the functions of the different anatomical aspects of the tract. And we're going to focus predominantly on sperm production. We're going to focus on erection and sperm ejection, known as ejaculation. Mm-hmm. And we'll talk about everything in between.
So they're the main physiological processes. So last week when we did the female reproductive, it was really around the menstrual cycle.
Yeah.
Today it's more so just the production of sperm.
Yeah.
Which would be, this term of the production of sperm would be generically called gametogenesis, right?
Broadly, yes.
So both female, male, female more specifically oogenesis. But today, because we're focusing on sperm production, it's spermatogenesis.
Yes.
But when we get to this point, you're going to throw a lot of similar terms at us.
Yeah, because there's spermatogenesis and then spermiogenesis as well.
And then there's
terms like spermatogonium,
spermatids, spermicide.
Yeah, spermicide, all that type of stuff.
Yeah.
Look, they're all very similar.
But we'll get there.
We'll get to that point. I think just to begin, we should just go through the anatomy and the fact that it's a tract. So the sperm are produced in a particular area of the male reproductive tract called the testes. Testes, plural, testis as one, not testicles.
Yeah.
Right? Testicles is more colloquial. This is something that we use down the street when we're like, hey, how are you? How's your testicles? But medically, it's testes and testis, or at least
Talking
anatomically.
of colloquial, can I give you some lists of colloquial terms?
For
external genitalia.
Okay, so are we begin with the testes?
Well, we can start. Well, let's firstly, do you want to go through all the reproductive organs and what's internal and what's external? Not just list the names.
Yeah, absolutely.
Okay, so we'll go external. The external definitely encompasses the penis and scrotum.
Yep.
Now, there is a degree of controversy whether you consider the testes as external or internal.
Yep.
I've seen some texts that will say it's external, some will say it's internal.
But the testes are internal.
Yeah.
Who says that they're internal?
Well,
because they're in a scrotum.
Yeah. Well,
but the scrotum
internally inside the body, I guess you can't directly see them like you would be able to the penis and the scrotum.
Yeah, I suppose so.
But today we'll call it external.
Okay.
Are you happy with that?
Yeah.
Okay. And I guess if you're going to call the testes external, you could, the thing that sits on top of it, the comma-shaped structure.
Epididymis.
That would be also included as an external sex organ.
So we've got testes, epididymis.
Penis, scrotum.
Penis, scrotum.
So they're all the externals.
You're right.
And then you go on the ductal or the tubular-like structure.
Oh, yeah. The pathway.
And so then you'll go...
The sperm's highway.
Yeah. So then you'd have the vas deferens.
Yep.
Into the...
Well,
then you go into the accessory glands.
Yeah.
So you would have the seminal vesicle, the prostate gland, and the bulbar urethral gland.
Yes. And between those, there's a urethra.
The urethra, which has dual function of both the transport of sperm or semen in this case now, and urine. Yep,
that's right. And so it leads to the penis itself, like you said, external again, and then it leaves the body. Yeah. So it goes testes, epididymis, vas deferens, then it goes to seminal vesicles, then it goes to ejaculatory duct, which is inside the prostate gland, then it goes to the prostatic urethra, then it goes the bulbar urethral gland, then it goes to the urethra itself inside the penis, and then...
Which you could say there's the membranous urethra and then the spongy urethra.
Yep. Yeah. And outside the body. So that's pretty much the pathway from sperm production in the testes all the way to getting out. And we'll go through exactly what each of those structures do and some interesting facts on each.
Okay.
But you want to go through some what?
So just with the three external genitalia structures, penis, testes, scrotum, I thought I'd just find some appropriate colloquial terms or slang terms.
Appropriate.
Not X-rated harsh terms.
Well, we'll be demonetized from podcasting and we'll be removed from YouTube. So, just to remind everybody, we are on YouTube. So you might be watching this on YouTube. If you are watching this on YouTube, you get to see images. Now, these are going to be diagrams. Because again, we'll get demonetized if we have photographs of this particular system. Unfortunately,
unless it's our own.
No, I think also we would be demonetized. I don't think that makes a difference. So ignore that. It's
we'll probably lose our jobs at the university as well.
Agreed. So I think what we're going to do is just have diagrams, images. And so have a look, go into the YouTube channel. You'll be able to see all these images as we talk them through. But, okay, begin with what? Testes?
Penis.
Begin with the penis. Okay, so what are you going to say?
So some common terms.
Right.
What was the movie with...
Here we go.
Was it... I can't remember. No, I'm going to continue.
Okay.
It was a reference of the spaceship taking off and... They just kept on cutting to different people.
Austin Powers.
Yeah, Austin Powers.
Austin Powers. Right. Yeah, yes. Oh my God, that's a giant.
Yeah.
And it'd be, Richard, get over here.
That's what I was thinking.
Okay.
So Richard's a good start because shortening of Richard.
Yep.
Dick.
Right.
So that's fairly common.
Okay. I don't know. I don't understand the link there though. Because Richard being a name and the shortening of it being Dick and then
I looked at it
being relevant to as a colloquial term for penis, I don't get that.
Well... I briefly looked into that and the shortening from Richard. So Richard apparently was a fairly common name.
Sure.
Middle Ages.
Name of the king.
And
many of them.
It was commonly shortened to Rich.
Yeah.
Which then, through rhyming, just went, or to Rick,
Right.
went to Dick.
Rich to Rick to Dick.
Yeah.
Right. Okay.
And then
ridiculous.
because
To be honest.
because it was such a common name,
Yeah.
they then said every Tom, Dick and Harry. Have you heard of that?
I have. Yeah.
So it just means it's a common term used.
But how did it then get
Into Dick, I don't know.
to penis?
Yeah, don't know.
Right. Okay. So there's one. Yep.
And then
that is
there's
a common one. I have to say.
And then there's like the terms you would use maybe with children. So like if you didn't want to be a gross term, you might say that you put your willy away or your doodle or
Okay.
doodle.
Yeah.
When I've got daughters, so I don't have to worry about those terms. But
Yeah.
I'd imagine if I had a son,
Yep.
I'd be using those terms more frequently.
Yep. Probably.
Dong,
Okay. Yep.
and then an interesting one is schlong. Now I did
What's the etymology of that?
I did look into that, and apparently it comes from a Yiddish term schlang,
Oh right.
which means serpent.
Okay.
So that's the only one out of
I
the
can
lot
draw the line there.
that
Yep.
has some close resemblance
Right.
to.
Okay. So there's some of the colloquial terms that we use for penis. What's the next one?
Well, penis, actually, the term penis kind of derives from tail, meaning tail.
From
But
what Latin?
Latin, but then that also comes from Indo-European origins, which all seem to derive from the male sex organ.
Okay.
Yeah.
Yeah. All right.
So there wasn't anything like fascinating with
No.
where the term penis comes from.
Yep.
The next one, which is probably more interesting, testes.
Testes. Yeah.
Okay, so
Etymology first.
sure. So the etymology seems to come from to make a testament or testimony.
Oh,
So
yeah.
to declare.
Yeah, to testify.
Witness.
Declare. Okay,
So
okay.
it probably first would mean you bear witness of male virility.
What does that even mean?
I mean, like if you were to see a male's testes, you would be able to say they are resembling maleness.
Oh, okay.
Yeah.
Okay.
So
okay.
it would be a testament to that.
Right. So that's historically the link.
But then it gets a bit cloudier because then maybe in Roman kind of literature,
Yeah.
they seem to say or suggest that it would also be able to declare testimony or witness within
Like
a
in
court
court.
system. And
Right.
so you know how we
Well,
would
only males allowed to testify.
possibly.
Okay.
Now how like people sometimes say, hand on your heart,
Yes.
swear, don't lie.
Hand on your.
Yeah,
Really?
on your testes.
Is that what they actually did?
Yeah, apparently there is some reference into that.
Oh. So maybe, I'm just guessing, only men were allowed to testify in court. And to demonstrate that, you had to put your hands there to say, I test. Wow, that is just odd.
Swear on my.
Yeah.
Well, that then comes to swear on my crown jewels that I
Crown jewels, that's
and
another
telling
one.
the truth.
So why crown jewels? Just the shape?
I guess it's
And it's
the most important.
important?
Yeah.
Okay, yeah.
So then the other terms: balls, nuts,
Yeah, know those.
tackle, bollocks.
Oh, yeah.
That's more British.
Yeah, they're pretty common terms.
Yeah.
But that's so interesting why we always have so many terms for these.
I wonder also
Structures.
whether castration,
Oh, yeah.
which would make a person a eunuch,
Yeah.
which then may
So there's
deem them,
removal of the testes.
which may mean that they are not able to bear witness.
Right.
I don't know.
Were they not able to testify in court?
I'm not sure. I
Interesting.
didn't go into that length.
And what was the third one? Scrotum.
Scrotum.
Okay, what's the etymology of scrotum?
Well, it could come from a term called scrotum, which means a skin hide, or scrotum, which means a leather quiver for arrows.
As in to hold them,
Yeah,
like a bag.
like a bag. Yeah.
Oh, that makes sense.
So the actual term meaning was a purse-like tegumentary investment of the testes,
Tegumentary investment.
which would be like skin-like
Yeah.
purse,
Well,
a
don't
skin
they-
purse.
What makes sense? Makes sense. Don't they use? Could be
Which
a
is close
joking-
because actually the colloquial terms is coin purse
right.
or ball bag
Yeah.
or sack.
Yeah. I mean, it makes sense because that's what it's resembling. Oh, so okay. Now, epididymis, external structure, like the little cap that sits on the testes. That means epididymis, upon the didymis.
I think the didymis is Greek for basically testes.
And I find this part interesting, and I haven't looked into it. But the term diddums, have you heard people go, oh, diddums, when they're referring to like their kid or whatever it might be? I mean, I don't think anyone really says it anymore, but you used to see it on TV. They'd be like, oh, diddums. Is that etymologically related to testes because it's offspring?
Good thought.
My little diddums?
I wouldn't imagine so.
My offspring? Like, anyway.
Who knows?
I find that interesting. I don't know if you know the origin of that, let us know.
Diddums.
So should we begin now at the testes and focus on sperm production?
I think we should come back to sperm production once we've done do you want to do the whole tract? Or do you want to just
We did the whole tract.
Just a bit more focus on each part?
No, I think we talk about sperm production while we're at the testes.
Okay.
And then that way we can follow the transit of the sperm all the way through to the epididymis and the vas deferens, and we go from there.
Okay.
There you go. You can tell that Matt and I don't sit back and prepare these
Not at all.
podcasts. That's okay. We're going to start the testes. So what do you know about the testes, Matt? How many do we have?
Well, before you thought there was 3, but as I pointed out, that was a golf ball.
So about the size of a golf ball?
Plums.
Sorry?
Size of plums.
I thought you were doing more colloquial terms, which is what?
I don't know the
Dimensions?
dimensions, no.
Probably about, 12 centimetres by... Oh, okay, I don't want to guess. That's fine. 2 testes located within the scrotum.
Yeah.
If you look into the testes... Well, firstly, the testes are located within that scrotum. So we should probably talk about the scrotum first of all, don't you think? Since it's the most external. So it holds the testes and the epididymis.
So we've transitioned to the
scrotum. I think so, right?
Okay.
Because it's important to say that a lot of people and a lot of students will ask, it makes no sense when you've got this whole body that sort of appears to be designed or evolved in a way that best suits it for its environment. Why would you put the most important structure of the body being something that holds your gametes, your sex cells, the thing that allows for you to reproduce? Mm-hmm. Why would you put it outside your body in this sensitive sac? Right? And it's a good question. And it's simply because for sperm production to occur, it must be 3 degrees lower than body temperature, which is 37 degrees. So it needs to be about 34 degrees Celsius. So it needs to be outside of the body, and that's what the scrotum allows. It holds the testes outside of the body to keep it cool.
Yeah, and there's a condition where the testes do not descend.
So what do you mean by that? So are you saying that originally the testes were inside the body?
Yeah, so I can go through a bit later.
Okay, you don't want to do it now?
If you want to. Oh, no, let's even, I'll come back to it once we've gone through the whole system.
We'll do it right at the end when no one's listening.
But yeah, it originates kind of lower thoracic, high lumbar.
That's where the testes, when you say originate, embryologically.
Embryologically, yeah. And then they have to descend downwards. And we kind of went through that last podcast with the ovaries.
We did. Malarian, Wolffian
duct, yeah.
Yeah, I remember what you were saying.
And then there's going to be a structure which is kind of termed the gubernaculum.
Good word.
Which would be pulling the ovaries down, but then the ovaries become fixed.
Yep.
And they are still in the pelvic cavity.
Yep.
But for the males, that keeps pulling it further. And because the further attachment of the gubernaculum is going to be in the genital swellings. So that's kind of the outer part, kind of where the perineum would be.
Right.
And as that gubernaculum is getting pulling, the testes have to kind of get pulled out of the abdominal cavity.
I don't understand the pulling. I mean, if it's pulling out, doesn't there have to be a proximal attachment of it below where the testes end up?
Yeah, there's a little bit left.
And what's it attached to?
Well, it's going to attach to the actual scrotum. So there's remnants of the gubernaculum
in the scrotum.
In the scrotum.
Gotcha. And so the testes are up, the scrotum's down and out, and it pulls it down into the scrotum.
Well, at this point, it's just a swelling. It's not a scrotum at this point.
Gotcha. So the swelling that you're referring to is what will become the scrotum.
That's right.
Pulls it down. Okay.
And it's just a skin pouch at this point.
Yeah.
Which is just a swelling.
Yeah.
That the homologue in the female is the labia majora.
Right. Yes.
But as in the latest phases of pregnancy, so you're talking late trimester 3, is where the testes will come out of the body.
Right.
And then go into the actual scrotum. So
So about
3% of full term male births will still have an undescended testy.
3%.
3%. And
Three out of every 100. That's
right.
pretty common.
And if it's preterm, it could be upwards of 1 in 3.
Wow, okay. And they just have to...
And so what that would then mean, if the testes is remaining inside the abdominal cavity, it is going to run the risk of the temperature issue.
Oh, that makes sense. And potentially could alter fertility down the track.
Correct.
Okay, that's interesting. So if we have a look at the testes inside the scrotum being 34 degrees, interestingly, we know that our environment can change temperature, right? So, I mean, we live in Queensland, where in summer it can hit 40 degrees Celsius. And in winter, well, not that cold, but still goes below 10 degrees.
Yeah, right? And single digits.
Single digits. And so what this means is that if the external temperature is changing, then the temperature of the testes is changing, which means it may not be the best environment for sperm production. So does that mean the testes are just at the whim of the external temperature, like a what's it called, cold-blooded mammal, right? Whatever the temperature is outside, that's the temperature of its body. No, we have developed strategies to maintain the temperature of the testes within the scrotum. 2 major types of muscles present, one within the scrotum and one that's within what's called the spermatic cord, which attaches various structures from inside the body to the testes, or at least communicate from inside the body to the testes.
And that will reflect all the fascia compartments that the testes have to push through as it goes through the inguinal canal.
That's right.
So through the deep ring into the superficial ring, or out through the superficial. But that canal, as it's pushing itself through, it's taken all these connective tissue layers with it.
Yeah.
And that's why all the wrappings around the testes and the scrotum, within the scrotum, are the way they are, is because the testes has a push through all these structures to pop out.
Yeah, push through the musculature of the abdomen.
Yeah.
So if we have a look at the scrotum itself, and this muscle, one of these muscles that we're referring to is called the dartos muscle. And this dartos muscle allows for the scrotum to wrinkle. And so if you think about it, when it's hot or warmer outside, the testes needs to cool down. So it needs to become more pendulous. That's the term. Becomes more pendulous.
Is that like a clock?
Yeah.
Those grandfather clocks.
That's right. So it doesn't have to swing like the pendulum on a grandfather clock, but it does need to hang.
You get bruising on your inner thigh.
That's okay.
If you're running on a hot day.
And you don't want to, chime the bells of midnight. So as it hangs down, that's the hanging has to do with another muscle, but the relaxation of the scrotal sac itself because of this dartos muscle will result in basically it becoming more pendulous.
Yeah.
But if it's cold, then the dartos muscle will contract and it wrinkles the scrotum up and basically thickens the tissue around that area, maintaining heat. And so
like a jacket almost.
Yeah. It's the
zipping the jacket up. To give it a nice comfort fit.
But then using that analogy, if it's relaxed, that means the jacket's unzipped. And that's not happening in this case.
Loose and letting
Then your testes hang out. I don't think that's what's happening. But so here's the thing, a wrinkly scrotum, because of the dartos muscle, there's something called scrotox. And you're the one that told me about scrotox. You're the one that introduced me to scrotox.
As a therapeutic agent?
Yeah, but you gave me the pamphlet. You said, check this out. No, I remember last time we spoke about this on one of our podcasts, you spoke about scrotox. I don't know if it's something that people actually do.
Frequently. No, there is mention of it, that people do this therapeutic approach for aesthetics.
So just like Botox, where they take botulinum and inject it into the musculature of the face to tell it to relax.
Which is I don't think it's a neurotoxin. I think it's just a muscle paralysis agent.
Well, it is a toxin.
Yeah.
But yes, muscle paralyzes muscles. And so
the dartos muscle is a bit like the muscles of facial expression.
Right.
So when we think of the muscles, skeletal muscles, this is where you have some degree of voluntary control over.
Well, not dartos.
No.
I can't consciously at will
contractor.
Yeah.
Yeah. So these muscles, well, actually, skeletal muscles generally will move joints and bones, right? So hence why they're called skeletal muscles.
Wow.
But the muscles
Learning
of
heaps of
facial
things.
expression,
Yep.
they're generally attached to skin.
And fascia, like underlying. Yeah.
And so they will move. Well, generally the muscles of facial expression are all orientated around the apertures or the openings of your face. So nose, eye, mouth. And so most of the facial expression muscles will have some degree on
Oh, interesting.
maintaining those sphincters, either closing them or opening them.
Yeah.
Now, a secondary function of those is to provide non-verbal expression.
Yeah.
Now, they do that because they're not attached to bone. Maybe some have a small degree, but generally they all attach to skin.
Okay.
And so they can move the skin around based by their contraction.
Yeah.
Now, some of them over time will lead to the wrinkling of your skin.
Yes.
And so then people would then inject Botox into those regions, particularly the frontalis, which is the one above your eyes that allow you to look surprised.
If you're watching the YouTube channel, I'm surprised.
And it kind of paralyzes that muscle, so it makes all the wrinkles flat.
Right. So effectively...
So with the same approach that you would
Scrotox.
use Botox for on your face, you could use it in your
Scrotum.
the scrotum or the dartus muscle, and it would stop wrinkling.
Why? But why? Aesthetics?
Yeah.
Really? I just
Well, I
don't-
guess
I just don't get that. That is something that I just find very difficult to comprehend, is that somebody would, I mean, each to their own, I suppose, but to have to do that, interesting, I suppose.
Well, I guess some individuals would see it, they are cleanly shaven. They might see that as aesthetically pleasing, and they may also see it being extra smooth
Yeah.
as also
A benefit.
advantageous.
Well, fair enough. Each to their own. So anyway, that's the dartos muscle, right? Helping maintain temperature. But there's another muscle, like we said, part of the spermatic cord. So if you have a look at the testes, it is held into the abdomen by, well, a number of different structures. So it's going to be held there by this muscle called the cremaster muscle. It's going to be held there by a ductus deferens.
Yeah,
right?
Generally the spermatic cord is this cord-like structure that has a multitude of things within the cord.
Yes.
And so part of that spermatic cord would also have muscular fibres, right?
Yep.
And so by contracting those...
But wait a sec. So we've got the cremaster.
Yeah.
We've got ductus deferens as a tube.
Cremaster or not cream master?
No, not the cream master. I think
It could be though.
that's the seminal vesicles, I think. So the cremaster, there's cremaster, there's ductus deferens, there's blood vessels, there's lymphatics, there's nerve fibers. So anything that needs to communicate from inside the body to the testes and vice versa is going to be in this spermatic cord. So basically it's bundled up, right, in this sort of sheath. Now, when we look at the cremaster, it is an extension of the internal obliques.
Right. And so this is one of the kind of the coverings of the testes as it's migrated through the anterior abdominal wall.
Oh, right.
Through the deep ring, inguinal ring, through the canal, and then popped out of the superficial ring.
Yep.
So in doing so, it's going to take the fascia or parts of the muscle of the anterior abdominal wall with it.
Yeah.
And so you're going to have these muscles, as you just spoke about.
And so there's
So the
also
cremaster, did you say is part of the internal oblique muscle?
internal oblique muscle, which means there are individuals. Have you seen those monks who have been trained to get kicked in the groin?
I didn't know they were monks. I thought they were just martial artists from that region of the world.
Anyway, I don't know. Firstly, why? But I believe, I could be wrong here, they've trained their internal obliques to be able to pull their testes up into closer to the abdomen, so that when they get kicked, they're not actually hitting the testes, because the testes have ascended up high enough to be spared from the blow, right? Because of the internal obliques.
Right. It can't be good.
How often have you been attacked and been kicked in in the scrotum? Probably more times than
Never.
never. No, well, that's right.
A couple of times we use a protective piece of equipment in cricket.
Right.
Maybe.
What hits you in the groin? The ball.
Yeah, the ball.
Okay. Not other players.
Not other players.
Right. Okay.
Generally not.
All right. So that's the scrotum. Anything else about the scrotum? So that's a cremaster muscle. When it contracts, it pulls it up closer to the body, right, to keep it warm when it's cold, and it relaxes it again, making it more pendulous when it's warm.
Right.
Again, maintaining temperature. So dartos, cremaster, these are the two muscles that help maintain adequate 34 degrees Celsius temperature of the testes, best for sperm
Why do you
production.
think it needs to be a bit cooler? Why do you think that process, compared to, say, oogenesis, which is in the body,
Oh, yeah.
why do you think spermatogenesis requires to be cooler?
Do we know the answer?
I don't know it.
I don't-
I'm sure there is.
I don't know the answer.
But I'm guessing most mammals
Yeah.
have this approach, right? Where the testes is outside the body.
Do you reckon it has something to do with pathogens and it being a temperature that's probably not great for the production of other things? Maybe, I'm just guessing here, pathogens or cancers, or maybe do you think it's that temperature is detrimental to other things and ends up just being more selective for, I don't know, I'm guessing. I wouldn't have a clue, to be honest. But we should look into that, and you shouldn't have brought it up because I don't know the answer. So it's no.
We can ask the listeners.
Yeah.
If you do know,
Let us know.
write in and let us know.
gubiosciences@gmail.com, or you can go to our website, drmike.com.au. Send us an email from there. There's another temperature regulator here. Should we talk about it? Because it's part of the spermatic cord.
Oh, we're here now. We've done the scrotum in conjunction with the spermatic cord.
Yeah.
So we might as well just cover all these structures all together.
Yeah. All right. So if you think about the temperature thing, right, you've got an artery that's going to be coming down, the testicular artery, that's going to provide oxygen and nutrients to the testes. Very important because the tissue of the testes needs oxygen and nutrients like everything else.
You also have arteries going to the cremaster.
Yes.
And also to the vas deferens. So,
And epididymis.
yeah. Oh, they have its own one, does it?
Oh, sorry. I thought you were just saying that these tissues all need to be fed. Whether it's its own one, I think.
These are separate arteries.
Gotcha, yeah.
Cremaster and vas deferens.
So it's coming down through the spermatic cord, but because it's coming from the body, it's going to be 37 degrees. So the thought is, well, if we've got the testes hanging outside of the body to cool it down, it's going to defeat the purpose if we're delivering it 37 degree blood. We need a way to cool that blood as it starts to move down towards the testes. And what we've evolved is this complex network of veins which look braided. So we call it a plexus anytime anatomical structures look braided. And it's a venous plexus called the pampiniform plexus. And what happens is as the blood drains away from these structures, particularly the testes, forming this braid, the testicular artery that moves down is basically encompassed or sitting within the braiding of the pampiniform plexus, so that the 37 degree, and it's in such tight contact, just separated by the vascular wall, that the 37 degree temperature is convected away into the venous supply that's being carried away. So the venous supply will carry that 37 degree temperature or that 3 degree temperature difference away from the testes.
Wow.
So that by the time the artery gets there to the testes, it's 34 degrees. Isn't that amazing?
It is.
That's absolutely amazing. So it shows that it is important to be 34 degrees, right?
True. Multiple mechanisms to kind of maintain that temperature.
Dartos, cremaster, and pampiniform plexus. What were we going to say?
Isn't there other locations maybe in the brain or the neck that do a similar approach of
Cooling?
Yeah.
Oh, possibly. Let's have a think about that.
I'm sure there are where that has almost the same approach where vein-like structures are wrapped around an artery to change the properties of the artery.
Yeah, there is, but I just can't think of it right now. But I think you're right.
I'm thinking for some reason the giraffe's neck, but that is not temperature, that's more blood pressure, right?
That's blood pressure.
Yeah.
Because what happens is as the head moves down, the vessel becomes occluded so that it stops it from popping off.
Okay.
Because the blood pressure of a giraffe's neck, the blood pressure coming out of the left ventricle of the giraffe's heart super high to go up the bloody 2 meter neck to get to the brain.
Yeah.
But then if the giraffe puts its neck down to eat some grass off the ground or whatever it may be, then the blood pressure is going to be enormous, right? Because it doesn't have to go up all the way to the top of the head.
An aneurysm.
So as it puts its head down, it actually occludes blood vessels to stop the pressure from going up. Yeah. All right. So that's enough about the scrotum. I think we should go on to the testes.
The only other thing I'll mention here is generally it's considered that the left testes hangs lower than the right.
Right. Yes.
Have you come across this?
Yes, I have. That's a good point. For most males, left testis hangs lower than the right.
Yep. Now, have you heard any reasons for this?
Yeah, I've got a couple of. Well, I've got one major theory. I'd like to hear what you think about this. Right. So, and if you have a look anatomically at the blood supply, the arterial and the venous to the testes, you'll see that let's focus on the venous, so the blood draining away. The right testes, which tends to be higher, will drain blood back into the inferior vena cava, and the left
This is the right.
That's the right. Yeah. And the left testes will drain its blood back into the left renal vein. And so the right one will enter the vena cava at a right angle, right? Because the vena cava is up and down. It's straight. It's vertical. So as it goes in, it needs to go straight across, and it might pull it up because of that angle that's present. The left, when it attaches to the renal vein is horizontal. So it just attaches straight at the horizontal portion. And so it has the capacity to be longer, potentially.
Right.
But then that doesn't really explain the difference. But the difference could be temperature related, because I did read an article now it didn't say why, but I just want to quote this article that I read. The article's titled "Thermal Asymmetry of the Human Scrotum," published in 2007. And they found that left side scrotal temperature was higher in postmen and bus drivers. But they didn't measure it in butchers, bakers, or candlestick makers, unfortunately. But they did find it was higher in postmen and bus drivers.
Is that because...
Why they chose that population, I am unsure.
Nor do I.
Anyway.
It seems bizarre.
So there seems to be an asymmetry.
Is that because they're just sitting down all day in one position?
Maybe not posties.
No airflow?
Posties wear pretty short shorts. So do bus drivers.
I just mean they're constantly... Well, posties may get...
They measured it inside clothing and outside clothing.
Okay.
And inside clothing, it was different.
Where was this study?
I don't know.
UK?
I didn't.
Because don't posties in the UK walk?
Maybe. They usually have smaller villages, don't they?
Whereas
Australia,
they have the postie motorbikes.
That's true. That's true. So I thought that was interesting. The cause as to why, what do you reckon?
For the temperature difference?
Yeah. So that attachment might, due to anatomical location, being the right, potentially being at a right angle, so as to pull it up, and the left being at the left renal vein might have the capacity to be a bit longer. Maybe the temperature thing makes more sense because we know that the testes will change its level depending on temperature, and this study says that left is warmer. So why do you think that's potentially the case? Any ideas?
Well, I've come across one.
Yeah.
And this was a hypothesis from a colleague who was a surgeon and a really good anatomist.
All right.
And his theory was that the left testicular vein has a greater hydrostatic pressure in it.
Oh, okay.
And so it's kind of more dilated. So it's probably not draining as quickly as the other side.
Oh.
Okay, so therefore it would encourage the testes to drop a bit lower because of that greater hydrostatic pressure.
I didn't know it had a different hydrostatic pressure.
And one of his arguments for maybe why it's got a higher pressure is because, as you said, the left testicular vein drains into the renal vein.
Yeah.
And that's obviously draining the kidney, but there's also going to be some drainage from the adrenal gland.
Right.
Which is going to be taking hormones from the adrenal gland. And one lot of hormones are the catecholamines.
Yeah. Wouldn't they constrict though?
And they would then cause the potential slightly small diameter downstream to where the left testicular vein comes in. So if that's a smaller diameter draining
It's
to
increasing the pressure back
compared to the inferior vena cava,
Yeah.
it's got a greater hydrostatic pressure within
Makes sense. Okay. You know what? I like that. That makes sense. We should probably confirm, but I tried to confirm and I couldn't identify. So that's interesting. So left hangs lower than the right.
Now, with that, there's also a condition called a varicocele,
Oh, yeah.
which
Yes.
would probably
I've seen
be
many of these when I was working in the
urology.
well, urology was one of the surgeries that was moving
Common.
through, but a hydrocele or varicocele.
Yeah, so these are all. So what I was going to mention here
Sorry,
is
go
the
on.
scrotum, the scrotal sac,
Yep.
has the potential to actually expand quite significantly.
Yeah, and there's many layers to it.
Yeah, and
Right.
so if you were to get anything that went down into the scrotum that shouldn't necessarily be there,
Yep.
then it has the capacity to get actually a lot bigger.
Yep.
Now, a couple of the things that could go down into the scrotum that shouldn't be there is intestines, and so that would.
Wait, what do you mean?
Well, this
Why
would be.
would you get intestines in your scrotum?
Well, this would be a type of hernia.
Because it had to move through.
That canal. So again, so these would be inguinal hernias,
Yes.
and there's two main differences or different types. There's the direct and indirect inguinal hernias.
So just explain anatomically, you've got the abdomen, and then we said that the testes early on had to move through the abdominal wall
Yep.
to descend out into the scrotum or
Yeah.
into that swelling. So it had to move through an inguinal canal.
Right,
to
which
do
is
so.
kind of in a close proximity to the inguinal ligament.
So there, it's going to be a weakened part of the
That's
wall,
right.
right? Because it's had something pushed through it.
And this is why men have a greater prevalence of inguinal hernias than females.
And so what can happen is the intestines, if it's severe enough, can force its way through, because a herniation is any time a structure moves outside of its designated region, right? And so it can herniate out without actually falling out in regards to the intestines. It can herniate beyond the barrier, but if it's severe enough, it can fall into the scrotum.
Yes, that's right.
And I know somebody in which that, I don't know if I told you this.
And so it can go down into your scrotum,
Yeah.
or it can just bulge out in kind of your groin. So that would be the difference between direct and indirect.
So direct into the scrotum.
So if it goes then into the scrotum, then it has the ability to fill up the scrotum.
So when I was studying, I was also working in retail, and had a friend come into work, and he said to me, "Mike, my scrotum is enormous." And I said, "What are you talking about? Why are you telling me this?" He goes, "There's something wrong. There's something wrong. Like throughout the day, my scrotum will get bigger and bigger and bigger, and it hurts. And then when I go to bed, I'll wake up in the morning and it's normal size again." And I said, "Mate, I think you've got a hernia. I think they're your intestines falling into your scrotum," which freaked him out. And he left work immediately and went to the doctors, and that's exactly what it was.
And he went and got a surgical mesh repair or something.
Yeah, mesh repair, holding it in. So, yeah. And the reason and the question might be, well, why would it fix itself up in the middle of the night? Well, you're laying down flat.
Gravity.
And due to the peristaltic contractions of the intestines, it pulls itself back in.
Okay.
Right?
And probably also just the
And gravity is obviously
gravity
weighing
and
it down.
the intra-abdominal pressure
Yeah.
during the day.
Yeah.
Hence,
So,
usually why when you're lifting heavy things,
yep. Which you would have no idea about.
it pushes through the most weakest part of the...
Oh, that would be a whole body.
So other things, so hernias, something hydrocele, as you said, that
Yep.
could be through just serous fluid. That could be,
Oh, okay. So it's just fluid that's been produced.
between certain layers of those testicular fascia.
Yep.
That could come from congenital reasons, so in the descension,
Right.
but also later in life. So adulthood, you could get hydroceles through like inflammatory processes and then just producing high amounts of serous fluid.
Yep.
And that would accumulate in certain regions of
The tissue of the scrotum. So I've seen this many times. It's actually more common than you would think. People would come in, and again, the scrotum is enormous, and just fluid filled, right? And so,
And I think the way they can see that if it's blood versus serous.
oh yeah,
is
it looks yellow.
You can shine light through it.
Oh yeah, you don't even need to do. You can just look at it. You can just, well, if it's big enough, you can. And it's big. I mean, I've seen it extremely big, and there'll be times in which, they just drain it. There's not much else you can really do. So you cut through the various tissues until you find the tissue in which that hydrocele or fluid-filled sac is present, and you make a little nick into it, and you just drain the fluid. So I remember one time I had to hold, the kidney dish that was going to be draining that fluid into while the surgeon is cutting, and then a part of the tissue peels away, cuts to the next layer, tissue peels away, goes into the next layer, and nicks the fluid-filled sac.
I think that's a tunica vaginalis.
Yeah. And then because it's under high pressure.
Oh, you got wet?
It squirted all over my scrubs. It went past the kidney dish onto my shirt and went all the way down my shirt and then went into the kidney dish. And I'm holding it, and then I just said, okay, I'm going to go get changed and have a shower now. It was gross. It was gross. But it's common, and this is just something that happened. The condition isn't gross. It's squirting on me was gross. Just to, when these conditions happen, people should go get checked. I'm not saying it's, you're gross. Please don't.
Yeah,
think
I
that.
think
People understand that.
Getting covered by any body fluid from someone else is gross.
Okay, thank you. I agree. I just wanted to say I don't want people to get it confused that it's gross and that they should be ashamed or anything. They shouldn't. You should go to the doctors and get yourself checked out and, sorted.
So there's some of the conditions. And I mean, more problematically, all these would be a condition that needs to get medical attention.
Yeah.
But a real medical emergency would be if the spermatic cord kind of twists on itself. So
I
a
know
torsion.
someone that's happened to.
So if it twists around itself.
How does that happen though?
I think it would again be the structures that the spermatic cord has formed.
Yeah.
And then maybe they're more lax.
Right.
Not as taut.
Would it have to be a particular event would need to occur?
I don't know. Maybe. Or it's probably got a congenital underpinning.
Yeah.
And if it has the ability to turn on itself, then the concern would be blood supply. So you are then restricting blood to the area, and necrosis would be the outcome you're trying to avoid.
Absolutely. So
and again, like any structure that you cut blood off to, you probably only got hours.
Yeah. Ooh, so
I think that's what they do to, not torsion, but when they castrate animals like sheep.
With a rubber band.
Yeah, they just put rubber bands around them.
I wonder if that's painful. I don't even want to think about it. I think it's a bit gross. All right, so the testes, site of sperm production, right? It's also the site of testosterone production. And so importantly, these are the two major products of the male reproductive system, and both are produced in the testes. So testes are extremely important in this process. If you were to take just the testis itself, testis, and you were to cut into it, you would see...
Which way? Longitudinally.
The
sagittal section of the testy.
Yeah, sagittal section of the testy. You open it up like a book, basically. You'll see that there's all these lobules inside. So these
250 of them.
Per testis, right?
Yeah.
And inside of these lobules are what's called seminiferous tubules. And so these seminiferous tubules, I think in total make up about 1.5 meters.
Yeah.
And
so I think there's between 1 to 4 seminiferous tubules per lobule.
That's right. Yeah, very good. You did your research, Matt. And the whole purpose of these seminiferous tubules is that if you look inside of those tubules, so now you do a cross section inside the tubule, so you're looking down the hollow.
So these are just pipes.
They're just pipes, but these pipes, if you use the example of like a PVC pipe, like a plumbing pipe, instead of
let's go with a garden hose.
Okay, garden hose. Instead of having like the rubber hose itself, the rubber aspect will be a lot thicker, and it's going to be made up of cells, a multitude of cells, and 3 really important types of cells that are present here are the spermatogonium, which are
germ
cells or stem cells, right? You're going to have Sertoli cells, also known as sustentacular cells.
Or nurse cells.
And then sitting outside the hose, because you're going to have, remember, one hose is one seminiferous tubule. So it's almost like if you were to hold in your hand 4 hoses, all cut in a cross section, sitting between each hose, you're going to have other cells. This is called the interstitial area, right? This is where we have Leydig cells. So you've got Leydig cells, also known as interstitial cells, that sits between the seminiferous tubules. In the seminiferous tubules of the walls, or closest to the walls, you're going to have Sertoli cells, and you're going to have spermatogonium.
Okay.
Now, this is the site of spermatogenesis, which is the production of spermatids, which are immature sperm. Then the spermatids will mature into more mature, not final stage sperm, but more mature sperm, and it's called spermiogenesis. And then that sperm will transport itself to the epididymis, which is that little comma-shaped cap that sits on the testes.
The posterior part of the testes, yeah.
And that's where the sperm will undergo its final point of maturation. And we'll talk about that in a second because a couple of other things occur under the umbrella of maturation. So if we look inside that seminiferous tubule, you've got the spermatogonium. Their job, as they mature into spermatids, they get closer and closer to the hollow lumen of the seminiferous tubules. Makes sense, and that's where it can sort of swim to the epididymis. The way this occurs, relatively straightforward, if we simplify it, just like with everything, I suppose, is that signals from the brain, once puberty hits, in actual fact, it happens a bit before puberty, but let's just say puberty hits 11, 12 years of age, the hypothalamus will stimulate.
So these are the same hormones that we've seen in the female reproductive system?
Exactly the same hormones, yeah. So they're called the gonadotropins, and they're released by the anterior aspect of the pituitary gland. And there's two types, follicle stimulating hormone and luteinizing hormone. Now, they're named after what they did in the female reproductive cycle, right? So follicle stimulating hormone stimulates the maturation of a single follicle.
So the follicle, because in the ovary example, they do have follicular cells.
Yeah.
That somewhat is this FSH is binding to. So you would say the equivalent of the follicular cells is the Sertoli cell.
Yeah, that's right. And then you've got the luteinizing hormone, which in the female reproductive cycle stimulated ovulation to occur, but in this case it stimulates testosterone to be released. So basically once puberty hits, these two hormones, follicle stimulating hormone, luteinizing hormone, are released into the bloodstream, travel to the testes, and follicle stimulating hormone, like you said, stimulates the Sertoli cells, also known as the sustentacular cells, to release a multitude of chemicals, which you could probably just broadly call androgen-binding proteins or an androgen-binding protein.
So it just makes the binding of testosterone more efficient to this process, right?
Yeah, exactly. And then the luteinizing hormone, so think of L in luteinizing hormone, stimulates the Leydig cells, also known as the interstitial cells, to release testosterone. And that testosterone will sort of diffuse into the seminiferous tubules and bind to the androgen binding protein that's released by the Sertoli cells. And this stimulates the process of spermatogenesis. Tells those spermatogonium, it's time, let's start producing what we call or what appear to be sperm or spermatozoa. But they won't become spermatozoa yet. They become spermatids.
Okay.
But in this process, there's complex genetic things occurring, right, in spermatogenesis. So if you think about it, and we sort of spoke about this when we did the female reproductive cycle in the last long form episode.
So the stages of meiosis, is that what you mean?
Yeah.
Okay.
And so it's a lot simpler here for the male reproductive.
Because it happens one go.
Well, that's right. For the females, it happened before birth and then happened at puberty.
And then at fertilization.
Fertilization, yeah, exactly. But if you think about it, right, all the cells of our body contain 23 pairs of chromosomes, one from mum, one from dad, for each pair, 1 to 23. Now, that's the same with the spermatogonium, the stem cells, but there's no point you're trying to create offspring, right, which is 50-50 you and your partner. So you can't give them
interesting.
23 pairs each.
Just when you said that, I came across a quote the other day that says, humans don't reproduce, they recombine.
Yeah, I suppose.
Whereas
that's
the only animals that reproduce are those that clone themselves.
Yeah, asexually.
Yeah.
Yeah, it's a good point.
Whereas for humans, we recombine.
Yeah.
Because then your children are half you.
Yeah.
Right? And then your grandchildren are a quarter you.
Yeah. Ish.
And then keep going, right?
Yeah.
I mean, we're obviously generalizing, but you get my point, right?
Yes, exactly right.
Whereas some animals would kind of just clone itself.
There will be clones for multiple generations. Yeah. All generations pretty much. So to that point, there's no point having a sperm cell or a spermatozoa having 23 pairs of chromosomes because that's all of you, right? And there's no point having an oocyte or ovum having 23 pairs of chromosomes because that's all of the other person. So you want half of that each so that half of you, half of them recombine, like you said, to produce a totally new, different individual.
Yeah.
That is a combination of you and your partner. So the spermatogonium, the sperm stem cell, has 23 pairs. So what it needs to do is it basically will double that.
So the first step is mitosis.
Mitosis. So it doubles. You're thinking, wait, this is the opposite of what we want to do. But it doubles. So now it has 2 lots of 23 pairs. And then it pulls itself apart. So now you've got 2 of these pre-spermatids, right, that have 23 pairs. And then these 23 pairs start to recombine.
Yeah.
So they start to mix with one another. And then the genetic material combines. So instead of you having the chromosome 1 that is in every cell of your body, you got chromosome 1 pair in every cell of your body, and they're identical, basically. So one of these sperm cells is going to have exactly that, but then the chromosome 1s combine and create a new chromosome, 2 new chromosome 1s.
Yeah.
And they get pulled apart. So now you have 4 of these early spermatids that only have a single chromosome 1 in them, a single chromosome 2, and they're recombined. So they're different to any of your chromosome 1s that you contain in all the cells of your body.
I think it's just it's an important point to just go back to where we have on that. So when we focus back to that seminiferous tubule, and it's like the hose analogy, closest to the wall of the hose. Is where the stem cell is, right?
Yeah.
So what is that term?
Spermatogonia.
Right. So that's the stem cell that will be starting this process off, right?
Yeah.
Now, you said the first step is to kind of double itself.
That's right.
Now, the purpose of that is because you've created 2, okay, but it's kind of a direct copy of itself.
Yeah.
One of those, which is the type A cell, okay, it will just go back to being a pool of stem cell.
Oh, very true.
So that way it just keeps cycling itself, which is part of the reason for why males can continue this process through the whole life, generally speaking, right? Yeah. Whereas
we make
in comparison
1,000 per heartbeat.
Wow.
1,000 sperm per heartbeat.
Okay.
Yeah, just to put into context.
Whereas in the female comparison, the number that they're born with is pretty much set.
Yeah.
And then obviously they're not going to go through. So if there's 200,000, you're not going to have 200,000 ovulations, but you're not going to be able to increase that number anymore.
Yes.
Whereas in the example here in the testes, you've got this the primordial germ layer or germal cell, which is a spermatogonia, right? That can keep going by generating this pool of ongoing cells.
Yeah. So what you're saying is from the spermatogonia, you can generate a pool of continual sperm cells up until, basically when 70% of 70-year-old males can still produce viable sperm, right? This doesn't happen in females. And it's because of this point is that they don't have a germ cell oocyte that can continually replenish other oocytes. They will have the oocytes present from birth, right? And then those will become depleted over time. And which is really interesting. I'm not sure what the evolutionary benefit is for that.
To keep going?
Well, no, to not have the capacity to continually create oocytes throughout a lifetime from a stem cell, an oocyte stem cell for females. It could be about preservation of DNA over time.
I wonder, my thought would be the difference in the egg compared to the sperm.
Yeah.
All the sperm is providing is DNA.
Yeah.
Whereas the ovum is the whole cell.
It's everything.
Yeah, right.
It does all the important stuff.
And so it gets to a certain age where it becomes deleterious for an offspring.
Good point.
There's going to be too many errors and so forth in it.
You're right, because basically all the mitochondria comes from the mum, right? All of the organelles, all of those things that are present to help maintain. Yeah, so I think that's probably a good point is that if it continued as we get older, obviously, you have a reduction in physiological capacity. So structures and functions diminish. And I think that would also be true for eggs and sperm, right? But like you said, because it's just DNA in sperm, it's probably not as much as a big deal because you're not passing on other things like the mitochondria, which are important for metabolism and process. I mean, super important. Okay, so anyway, they're just guesses of ours. So you said we had...
So the type A just continues the pool of stem cells going.
The other one has doubled its DNA.
Yep.
And now
so
it's
type B.
It's going to pull itself apart to create two.
And then that becomes the primary spermatocyte.
Yep.
Okay.
Which then combines.
Which then does another level of meiosis.
Yep. So combination.
Yep. And then that splits again.
Yep.
Which then...
Four.
So
now single, so what we call haploid, single cell, single chromosome spermatids.
Yeah.
Right? And so it's now these spermatids that can start to mature as it moves through into the lumen of the seminiferous tubules. Thank you very much.
And so as it's moving through, it's moving through these nerve cells or these Sertoli cells. So the Sertoli cell itself is kind of like a globular mass that it has to kind of push itself through, and it's providing that nourishment for all this process to happen. One being the antigen binding protein, but also it kind of causes a protrusion within the Sertoli cell itself, which kind of puts the Sertoli in two compartments, a basal compartment and a adluminal compartment, which means I think the adluminal compartment is probably more impacted by the testosterone levels. And I think it also plays an important role with the immune system.
Definitely. There's a testy immune barrier.
Yeah.
It's actually, the seminiferous tubules are immune-free. There's no immunological reactions in the seminiferous tubules.
Okay.
Do you know why?
Well, I guess it's got antigens on there that may be seen as...
Once you create new sperm, they would be seen as foreign.
Right.
Because they're recombined genetic material.
Okay.
Right?
Yeah.
So they're not self.
Right.
They're effectively not you, your sperm.
Okay.
Because it doesn't have your complement of DNA. It's got a recombined complement of your 2 chromosome 1s and 2 chromosomes 2 and so forth. So it needs to be immune-free.
And that's different enough to produce like an antigen response.
Absolutely. Yeah.
Okay.
And so it has to be immune. And so the Sertoli cells, like you said, that are sort of pushing their way from that basolateral wall of the seminiferous tubules, it plays a role in maintaining that blood testy barrier. It's really interesting.
Amazing.
So it takes 64 days for this process of spermatogenesis to occur. So 2 months, basically.
To go from a globular cell to then get to a cell that looks more like a sperm.
Yeah, which is that tadpole sort of analogy that we use.
That tadpole production is called spermiogenesis. So it's still part of spermatogenesis, but there's the latter phase of it is changing the cell from a globular-like cell to a tadpole-shaped cell.
Yeah, spermiogenesis, that's right.
And so this last process is important because the appearance of the sperm is kind of what dictates its ability to fertilize the egg.
Yes, but testicular spermatozoa, which is what we've now produced in the seminiferous tubules, cannot fertilize eggs.
Because it hasn't been activated yet.
That's right. It needs to be activated in the epididymis, and that's where it matures, is now it gets transferred to the epididymis.
But at this stage...
What's it look like? What are the different structures?
Well, I think the most important, and you can see this if you are watching this on YouTube, you can see the image that we're describing. But essentially it's gone from a globular cell that when we teach general cell biology, we always just say a cell looks like this round thing with a cell membrane and a nucleus in the middle and some scattering of organelles, right? But to make it into a tadpole, we've got to do some adjustments to organelles. So we start with the Golgi apparatus, which has the protein, generally the protein factory, right?
Yep.
And that starts to throw together a whole lot of proteolytic protein enzymes.
Yep.
And that forces to the front end of the cell.
The head.
It's going to be the head. And that's going to be important for what we call the acrosome.
Yep.
And that's important for its ability to go through parts of the the follicle.
Yes.
So the follicular cells and then the zona pellucida, and then to get success into the actual ovum. This acrosome is that structure at the front of the sperm.
Yep.
Now behind that you have the nucleus, and so this is the most important part of what the sperm needs to do, is to deliver that payload, which is the genetic payload. That's all you need to do, is just get that somehow into the ovum.
oocyte.
Now behind it you have an array of mitochondria. So we like jet packs.
Yeah.
That is just lined up with all the fuel for the long journey.
Mm-hmm.
And then behind that is this long protein-like structure, and that's a flagella, which is the tail.
So the tail also has mitochondria in it, and importantly, the mitochondria needs to create ATP for this tail to undergo motility. Do you know what the substrates are that the mitochondria will use for the tail to work?
Fructose.
That is one. So I found this interesting. This was new when I learnt this. If you look at the tail, you've got the mid piece, which is the part that's closest to the head, and then you've got the tail part, which is the longest portion, right, of the tail. The mid piece uses oxidative phosphorylation. So it uses oxygen to create a lot of ATP. It's slower, but creates more abundant ATP. The very end of the tail just undergoes glycolysis. So that means it uses glucose, fructose, and sorbitol are the three major fuels. But the mitochondria of the sperm can use, in addition to glucose, sorbitol, fructose, which are found in the accessory glands, which we're going to go through. So it provides that nourishment to the sperm through the process of emission ejaculation. But it can also use fatty acids. It can use ketones, and it can use lactate.
Ketones?
Yeah.
Wow.
Yeah. Interesting. Especially for all those meatheads out there who just eat meat only and produce ketones. But anyway, it's not the preferred energy source. Fructose, sorbitol, glucose, preferred energy source for the sperm. I just thought that was interesting. All right, so are we now moving that sperm through the seminiferous tubules into the epididymis?
Yeah, so now the Sertoli cell does this last kind of secretion and flushes it out through those pipe-like structures, which could be ballpark a metre long.
Yep.
Now, what it has to do in terms of movement is it has to go through the seminiferous tubules where it comes into the reti testes.
Yeah.
And that's kind of this confluence of all the tubules.
Yeah. Again, looks like a braided sort of network of tubules.
It's also sometimes termed the mediastinum of the testi. Okay. And then it kind of has these efferent ducts that leave the mediastinum of the testi and then goes up to the head of the epididymis.
Yeah, so then you've got like this confluence, this sort of collection of what looks like the seminiferous tubules, but they basically form an extremely long duct, which...
and that would be the equivalent. I mean, this is the two different structures embryologically come together. So the gonads came from a ridge, which is a different group of cells.
Yeah.
And the first part of the epididymis come from the Wolffian duct.
Yes.
That would be, that connection that you just described would be the equivalent of the frimbae in the fallopian tube.
Right, of the reti testes, or basically. It comes together to form the head of the epididymis.
Yeah, that connection between the two.
So now these seminiferous tubules basically form the duct of the the ducts of the epididymis, and they're like between 5 to 6 meters long.
Which part? The epididymis?
The ducts that make up the epididymis.
Wow.
And it's divided into a head, which is the top, a body, and a tail.
Yep.
And that then connects into the ductus deferens. But here at the epididymis...
Or the vas deferens.
Or vas deferens. Same thing, different name. Ductus or vas. I think we use ductus now because it's a duct. Vas, I think, was named after Johnny Vas, I don't know. But that's where the vasectomy comes from, so to cut the vas or to snip or to ligate or whatever they do with the vas. Anyway, something that sort of stops the spermatozoa from leaving the epididymis, basically.
Yep.
And then the question I get all the time is, wait a minute, you're saying that when I get a vasectomy, they cut my vas deferens, so I don't ejaculate sperm, I ejaculate something. It's like, yeah, well, it's or the fluid, you still, seminal fluid.
Which would be the majority of
prostatic.
semen
it's
is
the bulk of it.
Fluid from the accessory glands.
But no sperm.
No
Or
sperm.
at least shouldn't be. And
That's
then
why
the
you're
question is,
sterile.
and the question is, what happens to the sperm? And it just gets reabsorbed back into the body, just like the the primary A spermatogonia, or like the 20 odd oocytes that don't get selected for ovulation.
Per cycle, yeah.
Yeah. So same thing, right? Same thing. So we're in the epididymis. Now, here in the epididymis, maturation of these sperm cells occur. So this is where they obtain its motility. This is where capacitation and acrosome reaction capabilities also mature as well.
So this is kind of like, how you see the start of the horse race where they go into their
stalls.
Yeah. They kind of get lined up here,
right,
ready for an ejaculation.
To finalise the process.
That's right.
It's just like, okay. That's one way of looking at it, I suppose, especially today it's Melbourne Cup Day, so it's quite apt. Now, can you just further elaborate this point without going into too much detail? So they need to obtain their motility. We get that because we've spoken about the fact that it's simply just the fact that the proteins of the tail and the mid-piece and everything like that are just maturing, and the mitochondria are maturing. That's okay. But it obtains the capability of capacitation and acrosome reactions here. So what do those two things mean? Not necessarily what's happening here, but what's the relevance of it developing the capacity or the capability of capacitation?
Well, my understanding was the process of capacitation happens in the female reproductive tract.
It does, but the capability for capacitation happens here.
Right. So my understanding is that they just, at the headpiece end or the head end, they have these glycoprotein structures within them, and they need to be cleared or altered for maybe the acrosomal reaction to take place, which basically means as the head is starting to burrow its way through the follicular cells that are surrounding the ovum, they have to be able to kind of push their way through it.
Into the zona pellucida.
Towards that. And then you have certain receptors that can bind to the zona pellucida, so that they need to have these receptors exposed to be able to fertilise or to get the fertilising process to take place.
Yeah.
But I think once it binds to the zona pellucidum, then the acrosome almost inverts, so turns in on itself.
It flips itself in.
And then it kind of has a headpiece or like a crash helmet that is just a helmet of enzymes.
Yeah.
And then it's just burrowing its way through that zona pellucida.
Yep.
And then the first one that can make it through, there is another reaction where that has to bind. And once that binding has taken place, then there's this kind of cortical reaction, which is, I think, a wave of calcium processes through the egg, and that kind of then stops any further sperm being able to put its DNA into the egg.
Yeah.
And so I'd imagine those two processes.
They're getting prepared here.
Yeah.
Yeah, exactly. All those relevant proteins and they're enzymes, but are getting all prepared right here.
That's exactly right. It's interesting.
And there's fluid getting produced in here too, allowing for this process to occur. The epididymis produces fluid.
If you were to get an egg,
an oocyte,
oocyte,
not a chicken egg or anything, just for context,
and have it in a petri dish, and then just throw ejaculated sperm straight onto it,
it wouldn't work.
It wouldn't fertilise.
No.
So with IVF, they actually have to do artificial capacitation. So they have to do the cleaning process. And then they will allow the process to happen naturally. Yeah. But for some individuals, that acrosomal reaction doesn't take place. And then there's another process where stands for ICSI. I think that's just intracellular fertilization, where they actually have to get the sperm and inject it into the egg. Yeah. Which you've probably seen the videos for.
Yeah, they're the ones that you see in the movies.
Yeah.
Yeah.
And that's kind of a process they don't generally first go to, I don't think. Yeah. That's a later process, because you're not kind of allowing the strongest sperm to select for. Do you know what I mean? Yeah. So you kind of, this whole process from male to female fertilization is a kind of a survival process of the fittest kind of thing, right?
Yeah, because sperm, so basically when we say sperm, we're simply referring to the seminal fluid with the spermatozoa inside, right? So,
And there could be somewhere between 100 to 300 million sperm
Spermatozoa.
in one ejaculation.
yeah, with around about 3 to 3.5 mils of fluid that's associated with it. So that for humans, that is ejaculated into the vagina, right? So it has to move through vaginal mucus, cervical mucus, the uterus, fallopian tubes or uterine tubes in order for fertilization to occur. So it's an arduous journey with a multitude of things in the road. Obstacles, which are selective, right? And they're going to, so for example, sperm.
Like the Hunger Games.
In a way, yeah. So for example, misshapen sperm are negatively selected for at the vagina. And then once it gets to right. So then only quote unquote normal shaped sperm will make it to the cervix, and then there's mucus associated with the cervix and a particular environment with pH, which is selective again, and so forth. For mice, for example, they deposit their sperm directly into the uterus. Right?
Yeah. So other animals do this as well.
Right.
So I was going to bring this early up. They're one of the. I mean, it doesn't really fit here because we're talking about testes, but an odd-shaped penis is the echidna, who has a four-headed penis.
Odd for us, not for the echidna.
That's right. Yeah. A four-headed penis.
Four-headed.
Yeah, 4 heads.
Oh, not on its forehead, right? You need to be specific, Matt. So
a penis with 4 heads.
Oh, right. So with 4 urethras?
Yeah. Well, yes, that's right. I think there's some. I don't know how many marsupials have similar reproductive tracts as this, but I know that the
monotremes.
I know that the kangaroo is similar. They have not the 4, but they have 2. So they have a 2-pronged kind of uterus.
Again, with uterus or penis?
Uterus. But for the male kangaroo, it's only got the 2. But for the echidna, it's got 4, which means 2 of them rest during copulation.
Really?
And so then it kind of turns on itself, and then it can have another, maybe not the same female, but potentially.
So it can decide which
2 heads go in,
which urethras ejaculate.
Yeah.
Wow.
And then it rotates. And
so does that mean? So if there's specific control of each, is there different? So they each have different ductal systems.
Presumably.
So each have different testes.
Maybe not testes, but maybe just the final point that it comes out of.
Well, that's interesting. We need to look. Maybe, hopefully, for the YouTube channel, we can find a diagram of the echidna's reproductive tract, male echidna's reproductive tract, and put it up on the screen.
Right.
That'll be cool. Okay, if we can find it. So are we done with the epididymis?
Yeah.
And now we can start talking about the sperm moving through the vas deferens or ductus deferens. So this is a relatively long tube, right?
I haven't measured it.
Okay, well, that's interesting. And
I know the epididymis is fairly long, like you're talking like potentially 10 metres.
Yeah.
So that's quite long in itself.
But the vas deferens, I think, I'm not sure about, look, it's between 10 to 20 centimetres.
It sounds about right.
Something between there. But basically, the vas deferens will go from being from the epididymis, from the scrotum, up through the spermatic cord, and it goes into the abdomen, and it basically moves towards the sort of posterior lateral aspect of the abdomen, and then moves towards the posterior or back part of the bladder.
Yep.
And then sort of as it moves through the back of the bladder,
So it's kind of nested between the fundus of the bladder and the rectum.
Yeah, okay, yeah. So basically sitting between the bladder and the rectum. Mm-hmm. And here it starts to dilate a little bit, change its shape, and it turns into the ampulla of the vas. So again...
And that's going to be, lateral to that is going to be the seminal vesicle.
Yes, so whatever is coming through the vas deferens, which is going to be spermatozoa, so sperm with a little bit of fluid that's come from the epididymis, right? That is going to eject into a tube that will also have the seminal vesicles eject its fluid into as well.
Yeah.
And this tube is called the ejaculatory duct. So now we have a combining of seminal fluid from the seminal vesicles and sperm. And this ejaculatory duct is basically inside the prostate.
Yeah, that's right.
So now you've got
The central zone of the prostate.
Is that what it's called?
Yeah.
And so now the prostate is also releasing its fluids into this duct as well, this ejaculatory duct. So now you've got in actual fact, there's about 3 or 4 glands associated with the whole tract, right? The seminal vesicles, so if we have a look at it in regards to volume, you got the seminal vesicles, which make up
a lateral to the ampulla or the vas deferens.
Yep. So
that's still on the back of the bladder.
Yep. So that makes up 1.5 to 2 mils of total ejaculate, so semen. So semen's about 3 to 3.5 mils, right? So the seminal vesicles make up 1.5 to 2 mils of that.
So that's upwards of 70% of the fluid is from the seminal vesicles.
The prostate makes 0.5 mil of fluid, and the bulbourethral glands, which also known as the Cowper's glands, they make up there are urethral glands, but we're not going to focus on those. But the bulbourethral glands make up around about 100 or 0.1 mil, so 100 microliters of fluid as well. Generally speaking, there's slight differences between all these fluids, but huge overlap. They sort of all produce similar stuff. Some have produced one thing more than others and so forth. But basically, if you look at the seminal vesicles, they're producing water, carbohydrates, lipids, nucleic acids, vitamins, hormones, proteins, cytokines, prostaglandins, salts, and it alkalinizes the fluid. So it makes it more basic.
Which would be important for the vagina.
Which is acidic. So to combat that. Yes, exactly right.
Because my assumption would be the seminal fluid and the prostatic fluid would be important to go with the sperm.
Yeah.
But the bulbourethral gland is more preparing the urethra of the penis.
Absolutely
right. Just to lubricate it, to get rid of any urine.
Do the hand action.
Any kind of urine remnants out, and anything that's potentially maybe blocked it, and to also neutralise just the urethra, the spongy urethra.
Exactly.
But the other 2 is more for the sperm.
Yes, maintenance of the sperm. So it's got the nutrients that it requires.
So a big one is fructose.
The fructose, but also, again, it's got lipids and it's got nucleic acids and so forth that's present. Prostaglandins, and these are going to be important as, in a way.
2 things I came across.
Okay, I want to hear what you've got.
One, potentially causing a change to the smooth muscle of the cervix.
Yes, I've heard that.
And also to inhibit the female's immune system.
Heard that as well. Yeah, it I don't know about inhibit, but it modulates it in a way that makes it less likely to attack the sperm.
Going to what you said happens to your own body attacking your own sperm.
Yeah.
The female's body would see that and go, there's something not right here.
Yeah, it shouldn't be there because it's foreign, right? So of course it's going to identify it and attack it. So I think you're right. That's what I read about the prostaglandins as well, is it's an irritant in a way to the mucosal lining of the female reproductive tract, but also, like you said, modulates the immune system to make it less likely to attack the sperm. So it's moved now through, into the ejaculatory duct now which is in sort of sitting within the prostate. Yeah. So to describe the prostate, basically, unlike these other glands which sort of sit outside the tract and eject contents into a duct, the duct is sitting within the prostate.
Yep.
Right? And the prostate can be a relatively large gland.
So it's about the size of a walnut.
Yes.
And
but hopefully shouldn't have the feel of a walnut. That's when the issue
and it sits
arise.
Just under the neck of the bladder.
Yes.
And I think this is where it's got its name from, prostate, to promote like a state to be obvious.
Really?
Yeah. So it's like a thing that is. I did write it down. It basically means it just stands out.
Right. How?
To prostate.
Is that just through dissection?
I think if you were to look in that area, the prostate would be quite obvious as a structure below the bladder.
If you were looking through dissection.
Yeah.
So the thing about the prostate is obviously it is
prostate's Greek term, which means one standing before, or the protector.
Okay. So
guardian or protector of, in this case, the bladder.
very different to prostrate,
Yeah.
which a lot of students write in exams. Prostrate means to lay down.
Or to put your head down, yeah.
Yeah, so it's not prostrate. Prostate.
But interesting, the term prostaglandins come from this prostate, right?
Yes, it was the first site that prostaglandins were
Derived from.
but now we know
It's
they're made
not
by like every tissue in the body. So it doesn't
Well, probably
really
more
help.
correctly that prostaglandins is made by the seminal fluid, not the prostatic fluid. So maybe
Yes,
that
there's probably prostate.
maybe they just inspected semen and they were like, there was a lot of prostaglandins in here.
Yeah.
Must be from that gland that stands out.
I reckon you're right. The other thing about the prostate is it is like would you call it a fibromuscular tissue? And so
Yeah, but it's also glandular. So significantly it's gland,
Yeah.
but it will have a fibromuscular aspect to it, which helps with its contractile.
that's right. The contractile to help release its contents. But the thing with it is it has the capacity to hypertrophy, to grow, to change its shape and size. And the size, I think we did a whole podcast on the prostate.
Did we?
Do you remember?
And I did a video on it.
So we did a whole podcast
We'll
on
show you an image of the prostate
Yeah.
in these zones.
But it's important to realise that I think something like 95% of males over 80 will have an enlarged prostate. So prostatic hypertrophy. Not necessarily prostatic cancer,
No.
but hypertrophy.
And they usually come from different areas. So
But the size isn't necessarily the issue, right? Because it's the way that the tissue of the prostate grows. Because it can get bigger outwardly and it's not going to impact the tubes. But if it grows and it starts to impact the tubes internally, well, there's two tubes that's actually entering the prostate, right? There's going to be the ejaculatory duct, which is coming from the vas deferens and the seminal vesicles. But there's also the urethra coming out of the bladder.
Yeah.
Hence why any impact in changes to the tissue of the prostate could impact urination and ejaculation.
Yeah, and so within the different structures of the prostate, there's an area called the transitional zone,
Yeah.
which is the part that's most closely hugging the urethra.
Yeah.
And that structure, that histological region, is the one that's mostly impacted with that BPH, benign prostatic hyperplasia.
Yeah.
Whereas if you look at the peripheral zone, this is more on the posterior aspect of the prostate.
Yeah.
That's more impacted by the prostate cancer.
Yeah.
So it's kind of away from the urethra more than the transitional zone.
Gotcha.
And so with
enlarged prostate, which is quote unquote can be a couple of different things, like you said. The symptomatology can be different depending on the cause.
Yeah, you may not get the changes in urination as you would with BPH.
Yeah.
And interestingly, the peripheral zone is the one that's most outer part and in the most closer proximity to the rectum.
Hence the digital examination.
And that's why that's important, because if you were to feel an enlargement, but also maybe
it's usually the texture.
The texture, yeah.
Yeah.
But the transitional zone changes is fairly common, and that's because of, or one of the thoughts is the way that testosterone is modified into a more
estrogenic.
a more powerful form of, I think it's testosterone.
Yeah, dehydroepitestosterone, yeah.
That is done more frequently in the prostate, and that puts those cells under greater likelihood to alter or to become more rapid in their production, so hence the hyperplasia.
Yeah.
Now, because you're constricting the urethra, you are putting a greater challenge on the bladder to empty.
Yeah, yeah.
So that would then lead to, I think, an overflow type of incontinence.
Yeah.
But it could also lead to more problematic issues like acute kidney injury from a post-renal cause, which is the kidney can't empty.
Yeah. All right. So,
but interesting. The final thing I just want to mention with the peripheral zone, which again is the area that prostate cancers more frequently, the way that the prostate empties itself into the urethra, the central zone, which is in a similar proximity as the ejaculatory duct.
It's probably worth watching the YouTube video at this point if you're on the podcast, so you can see exactly what Matt's referring to.
it puts its fluid into the urethra on a vertical angle.
Yep.
Right. Whereas the peripheral zone puts its secretions in more of a horizontal angle, which means that the peripheral zone is more prone to get urine reflux. So urine can actually go back up into the prostate, which can then cause inflammation, which then may lead to prostatitis. But also it's thought maybe that is why the peripheral zone is more vulnerable to cancer.
Okay.
It's just the arrangement of the way the ducts get put into the urethra.
Interesting.
Yeah.
So yeah, have a look at the image, and then you can see all those different areas that Matt's referring to if you have the chance. Now,
can I say one more final thing?
Yeah, as long as it's interesting.
Well, the proteolytic enzymes that the prostate is producing
Yep.
is also so that plays an important role for the semen. It's thought to break down certain proteins in the female reproductive tract, but that hormone, well, that enzyme is also the enzyme that we can test for in males for the possibility of prostate cancer.
Because they'll produce more of it.
That's the thought.
Because the prostate's bigger, so you produce more.
Yeah, so that's what we call prostate-specific antigen, or PSA.
Yep.
And because that's just an enzyme, but if you are producing more of it, it's thought that the cells are more active, so that could correlate to the possibility of cancer. But it also would be high in BPH, and it would be also high in any irritation to the prostate gland. So it's not a specific.
Yeah, even though it's called prostate specific.
Yeah, that's right. And that's kind of come under controversy more frequently in clinical medicine because of, well, if you've got high PSA, go and get it looked at. Okay, go get it looked at. Oh, you've got high PSA, you must have prostate issues. Let's go and take it out. And that may cause more detriment on the male than it would be if you just left it.
Right, possibly.
Yeah, so it's a very, not controversial, but it's a difficult area to know.
So you treat the symptomatology?
Well, it's a combination of, yes, PSA if you are at risk. So if you have a history of prostate cancer, then PSA levels is important. And if that goes up over time, then that could be indicative of something worsening.
Yep.
But then doing in combination with the DRA, digital rectal examination, DRE, would also be important.
Yeah.
But then you'd have to maybe also consider.
Is that what Dr. Dre stands for?
MRIs, which is probably the new screening tool now that's considered, in combination with the most important diagnostic tool being the biopsy.
Yeah. Again, going back, I've spoken about a lot of my history working in the operating theatre when I was a young undergraduate student, just being a wardsman, just watching and these various operations. One, which was again quite common, was called a TURPS.
Yeah,
so TURPS, transurethral resection of the prostate, generally for non-cancerous prostatic hyperplasia, but transurethral. So basically through the urethra
and going out,
they would go in, they would put like a little burning tool through the urethra and they would start literally scraping away at the prostate from the inside out.
And would that be under radiography?
I can't remember. I don't think it is.
Wow.
Yeah. I think there's a camera in there at the same there's definitively a camera in there at the same time.
So they're just kind of looking.
They're looking
at
and
the
scraping.
pipe.
Yeah.
And just going.
And they're constantly flushing. I mean, for a TURPS, right? They're obviously scraping away not huge amounts of tissue, but it would fill probably 2-3 litre buckets of fluid.
You didn't spill this over yourself, did you?
I have very quietly, yes. Because what they would do is they would press the buzzer for me to come in to get rid of.
You're like a milkmaid.
Oh, well, basically, I would come in, they would press the buzzer.
Would you wear the same apron?
I would come in and because they'd press the button for me to get rid of the bucket, right, which is and replace it with another bucket. So I've got the bucket sitting there, empty bucket ready and waiting. They'd buzz me. I'll walk in. The fluid's like got a meniscal layer. I'm like, how am I supposed to take this out? And I remember taking it out because the doors for the theatre, you just push your back against it, right? They're just swinging doors. So I did that, and then as I moved through, the swinging door came back and hit my arm. I spilt it all over me, like litres all over me of warm. Now, most of it is just saline, but because it's warm and it's just yuck. Again, another time I had to change my scrubs and have a shower.
Another shower.
All right, so moves through.
Sounds like you spent most of the time in that job in the shower.
Not wrong. So it moves through the prostate now after it's released its prostatic fluid. And from there, it's now starting to move through the urethra. So the urethra...
Well, it's going to be the spongy urethra.
The spongy urethra.
Yep.
And as it moves through the spongy urethra, it's now moving through the main part of the body of the penis. So the root of the penis, the body of the penis, then the glands of the penis, and then that's the external
which is the head
urethral
part.
office.
Yep.
And then it's out. Now, just as we enter the root of the penis, so sort of like the base of the penis, you've got the bulbourethral glands.
Yep.
So these are very small glands that, like I said, release 0.1 mil of fluid. And like you stated, they're there predominantly to sort of prepare the urethral lining for the sperm to make, and the seminal fluid to make sure it's the best environment possible. Because we know that urine, in regards to what's in it, components, and pH, can be super variable. So if you've got remnants of urine in that urethra.
Yeah, it could be detrimental to the sperm.
Exactly. So it sort of allows for that lubricate, and also can lubricate the head of the penis as well as that bulbourethral fluid moves through. So now...
With the ejaculation,
yes,
what I came across was...
But I haven't spoken about ejaculation yet.
No, just in terms of the fluid.
Oh, okay. The ejaculate.
Ejaculate.
Yeah. Ejaculation is the process.
The first... I don't know how you say this.
Knowing you, you'll say it incorrectly.
Because ejaculation comes out in pulses.
Right. Mind the pun. Yeah.
Yeah. The first portion is mostly sperm.
Oh, you're saying of the fluid that comes out? Yeah.
With the prostatic fluid.
Yeah.
And then the seminal fluid comes in the latter end of the ejaculation.
Oh, right.
Yeah.
Didn't know that.
Yeah.
Okay. Interesting. And that's because of the contractile, because of the musculature associated with the fibromusculature of the prostate. I assume as it contracts over that time, it starts to release more and more prostatic fluid.
Yeah, and I wonder also, this is going to be the levels leading up from, the start of the excitation phase to the plateau phase to the ejaculation phase.
Yeah.
Leading up to those points, I'm sure, and we're going to talk about the different autonomic control here.
Yeah.
But I'm sure that the way that these glands are secreting their substances into the urethra happen at different points.
Yeah.
And so probably the seminal vesicles may kind of empty their contents at the kind of heightened level of the orgasm, opposed to the bulbourethra, because that would come early. And I think that is got a term to it, that fluid that can come up before ejaculation.
Yeah.
And that's also an interesting thing to consider, that if a male was to ejaculate and then sometime between maybe another event of sexual intercourse, there could be still sperm in the urethra.
Right. Yes, yes.
If you go into another sexual intercourse or it's just sexual event, the bulbourethra, which is producing the fluid to prepare the urethra.
Yeah, might put sperm out towards the gland's penis.
Which could then lead to fertilization.
Yeah, interesting.
Without ejaculating.
Yeah, of course. Oh, that's interesting. I believe that happened on an episode of Scrubs. I think he got his girlfriend pregnant without... Oh, now I can't remember.
I think he got pregnant by...
Not having sex with her.
Yeah, it just ejaculated externally, but it landed on her.
Something like that. I remember.
And they were laughing at him.
Yeah, they were all laughing at him. Poor guy. So, when we look at the penis itself, because we need to look at the anatomy of the penis, right? So if you were to look at a cross-sectional view of the penis, so basically just cutting it down, not down the middle, sort of cutting it so you're separating the distal and proximal aspects.
So if you had a sausage laying on the table and you just cut it in half into an anterior posterior portion, then that would be the cross-sectional cut.
Yes.
Yeah.
I mean, horrible way of putting it, but you're totally right. It got to the point.
Well,
yes.
you know the term wiener.
Yes.
That's named after like a Frankfurt,
Okay, that's true.
a Vienna Frankfurt.
There you go.
Yeah.
Okay. So again, another colloquial term. It's one of the reasons why we're going to get cancelled podcast. And I wonder if the terms that we're using will be okay for. I mean, this is all educational. We obviously are being a little bit silly in moments, but it's just to make something that people can sometimes find uncomfortable a bit more comfortable.
Yeah.
It's not for us. We lecture this stuff all the time and we don't make these types of jokes in our lectures.
Generally not.
No, generally we don't. But we're doing this just so a broader audience can actually feel a little bit more comfortable talking about things that they probably aren't comfortable talking about. Just so you know, before you complain about us being silly about a serious issue, we totally understand that. So if you have a look into the penis once we've performed this cross-sectional area, you've got a whole bunch of what we call spongiform tissue or spongy tissue. So you've got sort of three bodies within the penis. You've got two lateral bodies, which make up most of the penis itself, and these are called the corpora cavernosa. And this
They look like banana boats. You know those boats?
what's a banana boat?
You know those boats?
I only know the sunscreen called
You know
banana.
those boats that you see, they're inflatable,
Yeah.
that a whole lot of people sit on and they get towed behind a big boat.
Yeah. Is that
They curl up on each end.
right? Because of the swellings either side of it.
I remember that what comes to mind is Jaws. You know how they're right in
been a
Jaws,
long
and
time
then
since I've
Jaws
seen
comes at the back of it and takes a whole lot of them out.
Yeah. Okay. Well,
But it kind of looks like this curved like banana structure. The
corpus. Yeah. The
corpus because there's two of them.
Corpora cavernosa. So cavernosa because it's cavernous. So it's got a bunch of sinusoids. So it's
And this is going to
tissue-
be important for the erection side of things.
Yeah, so it's tissue that can be filled or engorged is the term with blood. And so basically these two bodies of spongiform tissue, similar to the type of tissue in our nose really, has
Erectile tissue.
erectile tissue, has an artery either side right down the middle of it. So, well, when I say either side, if you've got two of these corpora cavernosa bodies that make up the main body of the penis itself, there's an artery that goes right down the middle of each of them. Right? This is important. Then underneath on the what would be the ventral aspect of the penis, you've got another body, which is called the corpus spongiosum. Very similar, but its difference is down the middle, there isn't an artery. It's the urethra,
Yes.
right? So that's important. Now, on the dorsal aspect, you've got some of the veins. So this is where the blood's going to drain away. Now, are we talking about erection now?
We can do it. The other thing of just important note, a structure that wraps up the corpora cavernosa is like the tunica albuginea.
Yeah.
And it's like, again, using the sausage analogy, it's like that outer skin.
Yeah, it is. Yeah,
So it wraps both of those dorsal columns up really tightly.
Yeah. Again, don't need to do the hand.
Whereas the spongy doesn't have that same wrapping.
Yes.
And so that means it doesn't, when it enlarges with blood, it doesn't compress.
Yes.
It stays relatively open.
Spongy urethra doesn't.
Yeah, that's
yes.
right.
But when the other two enlarge, the corpora cavernosa, when they enlarge, because of the tunica albuginea, it compresses the veins.
That's right.
Now, let's keep that in mind because we're now going to talk about erection and ejaculation. So when it comes firstly to erection, we need to talk about flaccidity of the penis, right? So how does the penis remain flaccid? So generally speaking, if we look at the penis, it has somatic and autonomic innervation. So somatic is sort of like the innervation our skin gets, right? So
Are you talking motor?
well, both sensory and motor.
Okay.
It has sensory and motor somatic innervation, but also autonomic, which means sympathetic and parasympathetic. If we first just focus on the somatic innervation, it comes from what's called the pudendal nerve, and the pudendal nerve originates from the sacral aspect of our spinal cord.
2, 3, 4.
There you go. It allows for sensation, so touch.
S, 2, 3, 4.
Yep. It allows for touch sensation of the penis. This is important when it comes to sexual stimulation, but also provides motor activity to the muscles of the penis, which are called the bulbospongiosus and the ischiocavernosus. Now, these are more external muscles of the penis, which can be consciously contracted, but more so during an erection. So once an erection has occurred, these muscles can contract and are actually very important to contract for ejaculation.
The final point of ejaculation. Yeah.
That's right. So that's what the somatic aspect can do. Now, the sympathetic fibers of the autonomic nervous system, they're coming from the lower thoracic, upper lumbar, sort of like T11 to L2-ish.
This is sympathetic. Sympathetic.
This is sympathetic, yep. And what the sympathetic innervation does, so think of sympathetic as fight or flight, right? It maintains tonic contraction, so constant contraction of the smooth muscle of that spongiform tissue. So the corpora cavernosa and the spongiosum, right? And it also maintains constriction of the arteries as well. So you've got the smooth muscle is constricted of the spongy tissue in the penis, and you've got constriction of the arteries as well. Okay. This is all happening because sympathetic neurons release noradrenaline, and that's constricting these things. Now, what does that mean? Well, if you're constricting the arteries, less blood is going to the penis, so less blood will fill the penis. It remains flaccid. If you're contracting the smooth muscle of the spongiform tissue, it doesn't allow for those sinusoids to fill with blood either. Right. So in actual fact, the sympathetic nervous system
inhibits a
erection, maintains flaccidity, which also means because you're constantly contracting the arteries, the penis is actually hypoxic during flaccidity compared to other tissues of the body. Right. Now, if we're thinking about an erection obviously can be stimulated psychogenically or psychologically through erotic thoughts, but also through touch of the penis through that pudendal nerve is obviously sending those fibers. And that touch sensation can go to the cerebrum, and you can have conscious thoughts about that, so you can actually actively think about that, or it can have a reflex arc going into the sacrum and out of the sacrum.
So that's more touch driven.
That's more touch driven. And so you can have a reflex arc that happens from that touch sensation. And this is what can happen with individuals who have spinal cord injury. If their autonomic nervous system isn't allowing for an erection to occur, the reflex arc at the sacrum can.
Right.
So,
and then this could be also, how would possibly it play a role during sleep?
What do you mean?
Well, erection happens pretty much in every REM state.
Right.
So
I didn't know it happened in nearly every REM state.
Every REM cycle, there is something that happens neurologically that an erection would take place.
It's probably inhibition of the sympathetic nervous system.
And sometimes you may have heard the term the morning wood.
Okay.
Have you heard that?
I have.
And I think that's because you've just come out of more like a REM state.
Interesting. Okay. So, all right. Well, let's.
So presumably that means it's got more parasympathetic flow.
Well, or inhibition of sympathetic. Yeah, so it can be one or the other.
Oh, right. Okay.
And so, so if we look at the parasympathetic fibers, generally speaking, you can remember erection and ejaculation with point and shoot, right?
That's commonly used, and I think it's a fairly good memory tool.
Point is erection, parasympathetic.
P for parasympathetic.
Shoot, ejaculation, S, sympathetic.
Yeah.
So we need activation of the parasympathetic nervous system for an erection to occur. So these parasympathetic fibers arise from the upper sacrum, like S2 to S4, right? And they just do the opposite of like parasympathetic usually does of the sympathetic. So the release of acetylcholine.
Yep. And they go to the endothelial cells.
They go to the endothelial cells.
Which go around the blood vessel.
Which release nitric oxide.
Yep.
Tell the blood vessels to dilate. That does the exact same thing for the smooth muscle of the spongy tissue as well. And what this allows for is blood to leave the arterial system, engorge the spongiform tissue, fill that tissue up so much that, like you said, pressure is being placed on that tubica albuginea, and that pressure between the spongiform tissue and the tubica albuginea puts pressure on the dorsal veins where the blood is going to be leaving the penis, or just the veins in which the blood will leave the penis.
So it's like a compression stocking.
Stopping the blood from leaving the penis so it maintains there. And this pressure goes above 100 millimeters of mercury.
Right.
So if you think about what that means, right? Right. So think about this: the blood that leaves the left ventricle, 120 millimeters of mercury. That's
How did you know this? Modified blood pressure cuff.
I don't know how they know this. I don't think they used a modified blood
Maybe
pressure.
on the blue whale, which has the largest penis in the animal kingdom.
How big?
Like 15 feet,
Whoa. Okay.
something like that.
Okay. Well, I'm not going to.
Fairly long. But then you have some animals that, proportional to size,
Oh, yeah.
is a lot longer.
Like
Slugs,
really?
sea urchins. Yeah, because sea urchins have to
You've just named two things that look like penises already.
Penises.
So are they just measuring the whole organism?
No,
or
no.
They themselves have.
Well, a lot of these are hermaphrodites, so they can fertilize themselves, but
Self-fertilisation.
their neighbours as well.
Right.
And so maybe just to get
Is that the right term?
the phallus further across.
Is hermaphrodite the right term?
Yeah,
Oh, okay.
at least what I've come across. Yeah.
Oh, okay. Oh, that's
And so
interesting.
even with the sea urchins, the penile length changes depending on if it's in calm water or rough water.
Really?
Yeah.
Wow. Didn't know that.
Anyway.
So relative to its body,
They're the longest.
longest. Okay. Well, thanks for bringing that up.
Welcome.
So the blood pressure within the penis during
Skyrocket.
erection, skyrockets. Mind the pun, goes up, and it goes above 100 millimeters of mercury, which is huge amounts of pressure, right? That's enough pressure that it's similar to of the blood leaving the left ventricle,
Yeah.
which we know if you were to measure measure the distance of the blood that's being ejected from that left ventricle, it would go a couple of meters.
So do you think that's because the venous pressure is so high, it still has to bring blood in to the area, so that blood pressure has to go so high to still bring in oxygenated blood? Because obviously you can't, if you were to hold an erection for, I don't know, half an hour to an hour,
Yeah.
if you weren't getting any oxygenated blood in, it would.
Well, remember the penis is already hypoxic. So it's probably used to low oxygen levels. So I reckon it could maintain for a while, but this is one of the reasons that if people...
It's also a medical emergency, right?
Yeah.
Priapism,
Priapism.
which is just an extended period of an erection.
Yeah, which can happen if somebody takes, what's it called?
Viagra.
Viagra, which just stimulates nitric oxide so much.
Well, can I go back a step?
Sure.
So the erectile tissue is kind of like honeycomb.
Yep.
So it has smooth muscle cells wrapped around it.
Yep.
And so when you go to the erection process, which you said parasympathetic releases acetylcholine to muscarinic receptors on the endothelium. And to make it simple, they just produce nitric oxide. Nitric oxide goes to their neighbours, which is a smooth muscle, which goes around the honeycomb parts.
The sinusoids.
The sinusoids.
Yep.
And they generate an enzyme. Nitric oxide generates an enzyme called GTP, and that changes into GMP. Now, that process causes the alteration of calcium ions within the smooth muscle cell, and that essentially just drops calcium levels, which makes the smooth muscle
Less likely to contract.
more flaccid.
Yeah.
And now doing that, it causes the sinusoid to fill up with blood.
So ironically, flaccidity of the smooth muscle leads to an erection.
That's right. And so going to your Viagra point, Viagra basically stops the breakdown of guanine TP to GMP.
Okay. Did you even mention those?
Well, that was the enzymes. I said GTP to GMP.
Yeah.
The enzyme that does that was guanylate cyclase.
Yeah.
That gets repackaged by phosphodiesterase.
Yeah, people are sticking with you.
PDE, which is exactly where Viagra works. So Viagra.
So make it simple. Viagra what?
Inhibits the enzyme that breaks down the thing that drops the calcium away.
Gotcha.
And so you keep calcium levels lower in those smooth muscle cells for longer.
Gotcha. Yeah. Leading to
a longer state erection.
Yep.
Yeah.
Okay. So we've got the erection. We've got that sorted. Parasympathetic nervous system. That's what's being stimulated in this process, inhibiting the sympathetic nervous system. Now we need to talk about the process of ejaculation. And there's two main phases called emission and expulsion. And it involves...
So is it switching into a sympathetic flow now?
Yes, exactly right. So this involves the distal epididymis, the vas deferens, the seminal vesicles, the prostate, the prostatic urethra, and the neck of the bladder, right? So in the very first step of ejaculation called emission, the first thing that needs to happen is the neck of the bladder needs to close.
Yep.
And that's important because you don't want, and it's not about urine coming into the urethra, it's more so about stopping backflow
Sperm
of
going into the bladder.
sperm going into the bladder. Exactly right. And so what now happens is ejection of prostatic secretions. The organs of this are going to be innervated. It's actually complex. They're innervated by both sympathetic and parasympathetic, these accessory glands. But generally speaking, it's sympathetic overall. And so what happens is the sympathetic neurons that are going to be leaving the thoracolumbar area, they innervate the ducts, the smooth muscle, because all of these hollow tubes have smooth muscle associated with them. And it tells those muscles to undergo that peristaltic contractions, right? But it also innervates those other muscles that I spoke about earlier, those two muscles, the ischiocavernosus and the bulbospongiosus, which are somatically innervated as well. And all of these undergo rhythmic contractions.
Okay.
And it's these rhythmic contractions of this sort of pelvic musculature. And also, the pelvic musculature, I said, is under somatic control. So is the external urethral sphincter under somatic control. But there's no evidence that we voluntarily control this expulsion phase of ejaculation. We don't know how this works, right? So what I'm basically saying is that we know that important aspects of the body are controlled consciously through somatic innervation. Yet, under sympathetic innervation, ejection must occur or will occur, and we don't control that voluntarily, yet we need voluntarily controlled muscles for ejaculation to occur. Does that make sense?
Or is that for the last emission point?
I think it's all part of it. It's all part of it because you need the rhythmic contractions for the glands.
To put all that fluid into the urethra. I just thought the somatic outflow right at the end, I guess it's the emission end, because that's the final, right? That contracting the ischiocavernosus and the bulbospongiosis is the actual shooting out phase.
It is, but in a way, it's not consciously controlled.
Okay. Yeah, I think you're right.
Do you know what I mean?
Yeah.
But it is.
But it is.
So there's something happening that we don't understand in regards to us switching from, I don't know, it's a different state, whatever that may mean. And then you've got ejaculation occurring. Now.
And then once that would be considered the orgasm?
No. So ejaculation and orgasm are two separate things.
Okay.
But they're intertwined. What the difference is sort of tricky to pull apart. But ejaculation is obviously just the expulsion of the semen and the sperm. And the orgasm is an experience that is associated with this process.
Okay.
Right? So you can have orgasm without ejaculation. You can have ejaculation without orgasm.
Okay, got it.
Right?
Yep.
But they're entwined.
Yep. Okay. And so once the ejaculation has taken place, then you'll go through a phase of resolution, which is going back to the start. And I guess the sympathetic is then turned off. Is that right? Mm-hmm. And then you will have a period where you cannot...
Refractory period.
Yeah, where you can't get another erection for a period of time.
Yeah, and I don't think we fully understand that refractory period either. And is that it?
The only thing I'll mention is a fairly common condition, ailment that men may suffer would be erectile dysfunction.
Oh, yeah.
And that could come into play from psychological reasons. So everything you spoke about that leads to that excitement phase of an erection being psychological, mechanostimuli.
Yeah,
all
molecular, vascular, psychological, endocrinological, they're all
So if there were
involved.
things particularly psychological, so anxiety or certain maybe mental illness states
Yep.
that could impede the ability to start or hold an erection.
Yep.
But also there are organic causes of erectile dysfunction, and that could come down to things like atherosclerosis. So if you've got poor blood flow to that region of the body, then you're not going to be able to do all that process that we spoke about to engorge the penis.
Yeah.
And that could be through hypertension, through diabetes or other conditions that would impact blood flow to the region. Then treatment, as we spoke about, one of the most common treatment modalities would be the drug, Viagra, which does basically impacts that ability to keep calcium levels low in the smooth muscles to keep the erectile tissues engorged with blood.
I think another important clinical point is that when surgery is happening in this particular area, and it might be of the glands, it might be of the various structures, prostate, whatever it may be, it's important for the surgeon to be mindful of all the autonomic innervation because it can affect the process of erection and ejaculation. So that's an important thing to keep in mind. I see that Matt's looking at embryology.
Well, let's leave this.
Whew. No. So what do you want to say?
I think we covered it fairly well in the female reproductive.
So it's the same thing, right?
It's the same thing. It's just
Malarian.
It's just the differentiation of the ducts slightly change. So early on in embryogenesis, the gonad is undifferentiated, but one of the biggest players in what determines it to become a testy is the Y gene. So the Y gene has a sex-determining region in it.
The Y gene or Y chromosome?
Y chromosome, sorry.
Okay, yeah.
It's called the SRY gene in the Y chromosome.
So genetically, genetic males are XY and genetic females are XX.
Yep.
So that is what's termed the sex chromosome. There's 23 pairs, 22 somatic that make the body. 23rd pair is sex-determining or associated chromosomes. And XY male, XX female. So you're saying on the Y, there's a gene that does what?
It leads to the differentiation of the gonad. Because at the point of, say, 4 weeks embryologically, the gonad has not gone in any particular direction.
So you're saying if you were to take at 4 weeks an embryo, is that what it would be called at this point?
Yeah.
And you go, let's have a look at the genetics. This is XY, let's call this genetic male. This is XX, let's call this genetic female. Anatomically, indistinguishable, at least gonad-wise.
Yep.
Okay.
Yep.
So I think that's an interesting point to highlight as well, is that, it's at this moment that differentiation process has not occurred.
Yes.
So, but now it's starting to.
So the Y chromosome would have that gene on it,
Yeah.
which would then lead to a change within the gonad.
Okay.
Okay. Now then the cells within that gonad would develop, the Leydig and the Sertoli cells, which then would be secreting testosterone, and testosterone plays an important role here.
Yeah.
Because without testosterone, the embryo would be exposed to estrogen from the mother.
Yeah.
And so it's going to be more feminized.
Yeah.
But with testosterone, you're going to get changes. Now, one of the main changes is the ductal system that runs parallel to the gonads. So there's 2 ones you mentioned. You've got the Wolffian and the Müllerian. With testosterone, it selects for the Wolffian duct, and that's just going to produce all the ducts that we spoke about. So the Epididymis, vas deferens, and then going into the urethra, essentially. So it produces that ductal system.
Yep.
If that was to not develop, then you would select for the Müllerian ductal system, which would produce the uterine ducts and parts of the uterus.
And I think I said this in the female reproductive one, but so the default is a female reproductive tract. You need a positive selection for male.
Yeah.
Through testosterone.
Testosterone and Müllerian inhibiting factor.
Right.
Yeah, there's two.
Right, yeah. So you need to actively select for
Wolffian
male
duct.
and actively deselect for
Correct.
female. But with the absence of either of those, you'll get female reproductive tract.
Correct. Yeah.
Interesting.
Yeah.
Okay.
One final point I'll ask you is
Sure.
apparently
Have as many final points as you like. Do
Okay.
we have listener mail that we're going to read out?
I haven't sent you the emails, but you can read it. Yeah. So the question is, I came across, again, a quote that said the size of the Y chromosome has been diminishing in humans. Right. And it's predicted that it will completely disappear within, I don't know, they said 20 million years.
Okay,
I know
that's
silly,
a lot of years.
But
did you make that time frame up, or did they say
they said that?
Okay.
Now, but then they said that the important genes that need to be retained will just go onto another chromosome.
Okay.
How does that work?
That can happen.
Can you explain?
So usually bacteria can recombine through that means, in which you can have the translocation of genes jumping from one chromosome to another. But it happens in humans as well. I mean, there's times where you can have, through combination processes, you can have a gene change chromosomes. So it can happen.
Wow.
It can happen.
Okay.
Yeah. All right, is that the
That's
answer?
it.
Okay, cool. All right, are we reading some listener mail? You go first.
Okay, so this is from Brian, Dr. Brian Johnson, and he is...
No one sent us listener mail music yet.
No.
We get a whole bunch of emails and no one has sent us listener mail music. Come on, team. Let's do it. So Dr. Brian Johnson.
So it's topic requests is a subject of this email. Mm-hmm. And so Brian says, Dear doctors, thank you so much for your remarkable work. 2 topics I'm always looking to see more on. Yep. 1, psychopharmacology. Good and one. 2, neuropsychology.
Ooh, they are going to be tricky. But we've got a good friend who's a psychiatrist, and I think it could be potentially one of those episodes where we bring them on. What do you reckon? And I did a psychopharmacology. It was more so pharmacodynamics, but focusing on psychopharmacology. Could turn that into a podcast, but let me have a think. All right. So thank you for that, Dr. Johnson. That is awesome. Let's put that on the list, because I think they're 2 really important ones. All right, so we've got one here. This is from Aaron. Aaron has the subject viruses and the heart. Hello, Dr. Matt and Dr. Mike. I'm a student at Griffith Southport. What?
I do remember this student.
Okay, really?
By name.
Oh, okay. Well, firstly, hi, Aaron. It's nice to see you again, or hear from you again. I'm a student from Griffith Southport and studied, is that your course?
Yeah.
Pathophysiology, Pharmacology 2 last year, and still listen and watch the videos. That is what we call
committed.
A good, dedicated, committed student. Had a few questions regarding coronary arrest and viruses. If you can help answer, my nephew Blake, who is a very fit, athletic and healthy 21-year-old, had a cardiac arrest while walking at Burleigh. He has no prior health conditions at all. Leading up to the arrest, he was feeling extremely fatigued and complained of pain around his shoulder the night before he slept. He was fortunate that there was a lifeguard nearby who performed CPR straight away. Blake was also lucky as there was an ambulance nearby. Wow, Blake is very lucky, which took over the CPR and utilised the AED. To cut a very long story short, he did not suffer any brain damage or damage to his heart and recovered at Gold Coast Hospital. They have just installed an ICD. After running tests, the doctors do not know what has caused this to happen. A theory from the hospital is a virus could affect the electrics of the heart. So my question is, as I'm thinking it's intracellular and could be pacemaker cells, are there specific viruses which can affect the mitochondria in the cell? And how long down the track can a virus damage the cell, then cause the dysfunction? Any information or resources that you could suggest are appreciated. Thank you for your time. Warm regards, Aaron. Thank you, Aaron. All right, so to begin with, yes, viruses can affect multiple tissues of the body, and one susceptible tissue for a range of viruses can be the heart. Now, the thing is that what the viruses end up doing is it tends to damage the cells of the heart itself and can damage either the myocardium, or it can damage the modified myocardium, which can also be what we call the electrical components of the heart. This type of damage, anytime you have damage to an aspect of the heart itself, because the heart functions as what we call a syncytium, which means that...
As a whole unit.
A whole unit. So when one muscle cell has an an issue, it can sort of extend to other tissues and it can play a role in sort of modulating the way that heart works. And so it doesn't necessarily take a lot to damage the heart for the heart to have dysfunction.
And that's how we saw a lot of myocarditis in the vaccines for COVID even, right?
Yeah.
So that something in the vaccine, probably the immune reaction to it and the cytokines, caused low levels of myocarditis in particularly young, teenage males.
Yeah.
But then when compared to active COVID, that was significantly worse.
Well,
and so
right.
the virus, COVID in this case, having quite a profound impact on the muscles of the heart. But also more recently, they've shown that COVID as the process that comes after the infection leads to atherosclerotic pathogenesis.
Yeah.
So they've actually seen quite a large uptick in cardiovascular events by people being recovered post-COVID.
From the virus itself.
That's right.
So the thing is that there's heaps of viruses that can cause this myocarditis. COVID, like you stated, Hep B, Hep C, parvovirus, common cold, herpes simplex virus, Epstein-Barr virus, rubella, plus bacteria.
Probably goes on and on.
So
and to tease apart whether it's the virus itself or the immune response to the virus
is difficult.
It'll be challenging, right?
But also you need to take into consideration, while your cousin may not have had any identifiable underlying conditions, it's really difficult to know whether somebody sits with a background of susceptibility, whatever that may be. And I'm not saying that is the case, but as we know with COVID, for example, COVID seems to be recognised as a vascular disease now. And because blood vessels are everywhere, some people might have their effects more so neurologically, some might be cardiovascular, some might be gastrointestinal, some might be renal. So this seems to be the reason why there's so many vast, broad effects in regards to different people having different issues with COVID, is because it's a vascular disease. And so I think what Matt and I are trying to say is that it's very complex and it could be a multitude of viruses affecting a multitude of cells. Not necessarily in your question about it affecting the mitochondria. I'd say that that's probably too reductionist. It's going down too deep. These viruses can simply just affect the overall function of the cells, just generally, and that can impact the way that the heart works. So hopefully that helps. Fingers crossed.
Yeah, and all the best with your cousin in his recovery.
So who do we have here? Chloe?
Chloe's subject here is neuroscience.
Ooh.
So Chloe has asked whether we've made any videos or whether we would potentially make some videos on motor neuron diseases.
I've touched upon it.
So whether, motor neuron disease, because her granny presumably may be suffering from this, so she'd like to know more on that.
Yep. So or amyotrophic lateral sclerosis, ALS, or MNS, motor neuron, MND, I should say, sorry. I've created a video on motor neurons themselves with a highlight on what can happen with motor neuron disease, because you've got upper and lower motor neurons. Mm-hmm. Each of them have different functions in regards to the way that they can affect the musculature and the way it contracts and the way that they sort of speak to each other. So upper versus lower lesion issues, which is what you can get with motor neuron disease and ALS, can have varying symptoms. So I think if you watch that video, type in Dr. Mike motor neuron, you'll be able to watch a video that may not explicitly focus on those diseases, but it gives you an indication as to how
the symptomatology
occurs from different upper or lower lesions happening. And that, my friends, is a 2 hour and 15-minute episode on the male reproductive system. We hope we've done it justice. Again, if you've stayed to this point, good on you. You can contact us through social media at Dr. Mike Todorovic, or you can go to our YouTube channel and watch this video, and you go to our website, drmatt.drmike.com.au. We really hope you enjoyed this episode. Again, we know we're a little bit silly at certain points, but that's not to diminish the importance of this topic. It's mainly just to make it a bit more enjoyable. And for some people, it is difficult to talk about these structures and functions. So we just wanted to make it a little bit more all-encompassing and relevant. So thank you, everyone. Thank you, Maddie.
Thanks, Mike.
Speak soon.
See ya.
Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.